Hello guys, am I audible and clearly visible to you? Let me know in the chat box. Am I clearly audible and visible to you? Good evening, good evening. I think on my from my side it's perfect, right? Let me know in the chat box. My audio and video is clear. We'll start this session. Everything is good, right? Perfect, perfect. Okay, okay, doctors. All right. So today's session is about for your radiology previous year questions discussion, and as per the radiology is having the weightage of good weightage in your FMG. Sometimes they are asking like 5 questions are on the blueprint, but sometimes they in the recent we saw that they asked 7, 8, 9, 10 questions also. And this is a good important subject. We can a short subject is it, but the importance of this subject is that that is integrated with the other subjects, right? So that's why this is a very important. If you understand the radiology, it will be much better for you. Like in the surgery, I'm giving you the example of the surgery. In the surgery, some questions are given as the investigation. They given you the some CT scans or MRI should be given to you, and as they given you this CT scan or MRI should be given, so you can make the diagnosis on the basis of it. Okay, so this is a much better thing if you are understanding the radiology concepts, so you can directly make the diagnosis of it. And as you make the diagnosis of it, so I think it will be quite easy to you understand and make to get it the answer which is the correct answer of it, right? So that's why the radiology is very important question. So starting with this session, as I already told you, the way of our test our this PYQ session is like that. I will show you the MCQ, and you have to answer in the chat box, which is the who was watching the live. You guys have to reply in the live chat box, and surely I will wait for the 10 to 20 second for you, and I will surely then explain you the question of particular question, right? This is a very important subject, and don't miss this subject, right? Very have the short session of this particular topic, right? So let's start this session of the radiology. Okay, so the first question I'm showing you in the front of your screen. I think it's clearly visible to you. A 42-year-old male patient come to the emergency room and with the chills and the rigors. So I have to highlight all the things which is the important. So the patient is coming with the chill and the rigors. The important thing is mentioned by the uh, our examiner. He is want to ask you, or maybe sometimes they want to confuse you about it, right? And he is having the acute pain in the right flank region. So the pain is also there. The right flank region, the pain is also there. Okay, and with it, this is not only there, right? The second thing, he has a history of the diabetes also, guys. Now you can understand the patient is a diabetic, come with the right flank pain, and there is a rigor. The chills are there, the rigor is there, right? So you have to make the diagnosis of it, and they are asking you just for the diagnosis. In the radiology, they are asking you just for the diagnosis. So the options are given. The option A is your cholecystitis. Option B is your emphysematous pyelonephritis. Option C is your small bowel obstruction, and option D is your volvulus, right? So what is your answer, guys? I'm waiting for your answers in the chat box. I'm waiting for your answers in the chat box. Everyone who are watching our live, please try to reply me in the chat box. Okay. Okay. And they shown you the image also. They shown you the image also. If you want, I can zoom into this image, right? I can zoom into this image. So I think you will get something from this particular image, that what they are asking to you. I zoomed in into the image, so you can see that here we can see what is this. This is the right flank region, and I can see here the some exudates are accumulating here. Okay, so this is all the exudates are here, and with the exudates, right, with the exudates, you can see here little bit air is also there. Okay, and now if the air and fluid both are there, right, if air and fluid both are there, so this will be your Emphysematous pyelonephritis. What should be the answer? Your answer should be B, not the A, guys. Cholecystitis will be not there. Cholecystitis, I will show you the imaging of the cholecystitis, right? So what you can see in this particular image, what we can see this is the perfect image of your emphysematous pyelonephritis. This is the image of your emphysematous pyelonephritis, right? Okay. And the important thing, please remember about the diabetes also. The key feature of it, the diabetes and the chills and the rigors, because our emphysematous pyelonephritis is having more commonly seen in the diabetes patients, and although it is having the important feature of the chills and the rigors, right? So you have to remember with this. Okay. Okay, very good. Yeah, clearly it is very clearly seen. Black dots are your air, right? You already know this is the X-ray image which I shown you. So on this, there is a air will be seen the black color, right? So there is a clearly black color. Small dots are seen. I can zoom in again, so it will be clearly to visible to you. Very good, doctor. I think I have to erase it, so it will be clearly understandable for you, right? Can you see here? Now you can see here. So this is your emphysematous pyelonephritis, right? Very good. I hope this question is understandable for you. Quite easy question. And now you can understand why, if you don't know about the acute pyelonephritis, about your emphysematous pyelonephritis, and you don't know about the clinical features, like this is more commonly seen in the diabetes patients, or it will be seen with the your chills and the rigors, right? But you know about it by the imaging. If you understand, if you make the diagnosis with the imaging, it's quite easy for you to get the answer of particular MCQ. All right. Okay, guys. Let's move forward. Right. So the answer is B. Right. Remember this, emphysematous pyelonephritis. Okay. This is your emphysematous pyelonephritis. Let's move forward. Please understand, what is this your emphysematous pyelonephritis? This is your severe bacterial infection, guys. This is your severe bacterial infections of the kidney, which is causing a gas formation. As I told you, there was the air was seen there, which is a black dots was seen there. That was your air, from where the air is entered into your okay. Sure. I will surely mention all the keywords. All the keywords I will mention, right? So it will be quite easy to remember for you guys. Okay. So now just remember with this, that this is a particular severe infection which is seen in the kidney, in the infection which is seen in the kidney, and it is causing the gas formation. So now you can understand, as the gas formation is there, we can see the air in the kidney, right? How the air can enter into the kidney, because this is a gas forming, bacteria are there which can make the gas in your in your kidney. So it is seen in the within the renal parenchyma. So what we can see in the renal parenchyma, what was the scene? There was the scene, the air was there. With the air we saw, with the air, which is the gas, right? The gas, with the gas we saw, there was the your pus was also there, exudate was also there. So the exudate and the gas, exudates and the air will be mixing there. So we can identify on the X-ray. This is about your acute. And please remember, this is most commonly seen in the your diabetes mellitus patient. Okay, so make a word, or this particular keyword, important keyword, that this is more commonly seen in the most commonly seen in the diabetes mellitus patient, DM patient. Okay, so remember with this. All right, I hope you understand. For this, again revising you about the image, please check about the image. This is your right flank region of the patient. So on the right side of the kidney is involved in this severe infection, and this particular person is having in the right side emphysematous pyelonephritis. The patient is having the right side. The patient is having the right side emphysematous pyelonephritis. Okay, guys. What about the others? I can show you the other options also. Like if I'm talking about your small bowel obstructions. So in the bowel obstruction, the bowel will be seen. Okay, the bowel will be the clearly seen into this. But here we are not seeing the bowel. The bowel is not clearly, bowel is not visible here. If the gases in the bowel was there, the obstruction was there in the bowel, so the clear bowel was seen there. In the volvulus, you know about the coffee bean sign is clearly seen, right? Surely I have this in this PDF. We have the volvulus also. The coffee bean sign will be seen there, right? So we'll talk about it, right? So this is all about your emphysematous pyelonephritis. Mark about the chills, rigors as a keyword. The second is the right flank region pain. Of course, the pain will be there. And the important is the diabetes mellitus, which is the keyword, because this is the most commonly seen in the diabetes mellitus patients, right? And this is the severe type of the kidney infection. Okay, guys, right? Should we move forward? Should we move forward? Okay. So the next question in front of your screens, guys, you can see there, a 3-day old newborn, just only 3-day old, just 3-day old newborn is come to with the bilious vomiting, guys. Now the thing is here, the bilious vomiting is the keyword here. Again, I can mention you all the keyword as a little star. Okay, so this star will be like the, if I'm mentioning a star on any word, so that will be your keyword. Okay, that will be your keyword. So you will understand in the later part when you are seeing this. Watch this PDF, or if you're watching this session in the recorded format, right? Okay, so this is the bilious. The first thing is there, bilious vomiting is there. Which sign is seen on the radiograph? So they are asking you about the sign on the radiograph. But the one thing, very good guys, very good, right? You are answering very well. Cholecystitis and pyelonephritis. Okay, cholecystitis is your gallbladder. The gallbladder inflammation will be there. Okay, in the cholecystitis. Pyelonephritis is your kidney disease. Okay, kidney inflammation, severe inflammation in your kidney and the ureters also. This is involving the ureters also, right? Very good. So let's come back to this topic. Very good, guys. I am seeing very good answering in your chat box, right? The first of all, answer me. This is the which sign? Answer the sign. Which sign is it? And please, I'm mentioning again here, this is the bilious vomiting is clearly mentioned there. So what do you mean by the bilious vomiting? Anyone of you can tell me? Okay, so this is your what? Exactly. Very good, guys. And this is the important, this is your double bubble sign. What is it? It is your double bubble sign. What do you mean by the double bubble? Let's check about it. I'm zooming into your image. Okay, so I think it will be clearly visible to you. Yeah, perfect. Okay. So now you can see here, this is the particular X-ray image which is shown you. Just 3-day old newborn is there, right? And as the esophagus will connect, this is your stomach. What is this? This is your stomach. And after the stomach, you can see this is the pylorus of the stomach. After the stomach, what is this? This is will be your duodenum. This will be your duodenum. So now this is the gas which is passing from there. The gas is going to the stomach. After the stomach, it will be at your duodenum. And after the duodenum, we cannot see anything. This gas is not moving further there. And this is having double bubble, right? So it is having the double bubble sign. And now let me know in the chat box, guys. I'm waiting for your answers. In which conditions the double bubble sign is seen? In which kind of conditions we are seeing the double bubble sign? I'm waiting for your answers, guys. In which condition you are seeing the double bubble sign? I'm waiting for your answers, guys. So this is your stomach and this is your duodenum. So now you can understand that in the duodenum, the part of duodenum, there is the opening of your biliary duct, right? So the biliary duct is open there. So after the biliary duct, if the patient is, the child is doing the vomiting, so the bilious vomiting is there, right? Bile to aa raha hai, right? So this is not your acute pyloric stenosis is not there. Okay, so stomach pylorus part is not the stenost, right? So duodenum is open till the duodenum. So it is seen in your very good guys. It is seen in your in the child. If I'm talking about in the child, it can be seen in your duodenal atresia. Very good. And your annular pancreas also. Very good, doctors. Very good. Right? You're replying very well. So this is sign of, this is your double bubble sign. So the two bubbles are seen in this condition. One is from the stomach. The second bubble is your duodenum, right? So please mark this word. This is your bilious vomiting. Now, any one of you can reply me in the chat box why I mentioned this keyword as the bilious vomiting. If there was a not given of the related to the bilious vomiting, then what will be the answer? Why the bilious vomiting is keyword mentioned there? So every time, please remember in the question also they're giving you the little bit sign, but in the image, if you remember the image, you can identify through the image, so it will be much better for you, right? For much better for you, so understand to the understanding of it, right? So in this case, if you are seeing in this case, what is this case? This is the case of your duodenal atresia, right? So this is the case of duodenal. So double bubble sign is seen there. Surely we'll talk about the triple bubble sign also. There is the one triple bubble sign is also there, right? So the image of triple bubble sign is also included in this PDF. So we'll talk about in this chapter. So we'll talk about it in the later part, right? So remember about the double bubble sign, right? So this is the double bubble sign, stomach and your stomach and duodenum will be seen. Yeah, the duodenal atresia is the idiopathic. Most commonly, it is cause of the idiopathic. Okay, idiopathic, most common cause. Okay, so double bubble sign is seen in your duodenal atresia, or you can say the duodenal stenosis also. You can say the duodenal stenosis also, right? So please remember your double bubble sign is seen in your duodenal atresia or duodenal stenosis. So this is the two things which is there. So please remember about it, right? So duodenal atresia. So duodenal atresia. Atresia, what do you mean by the atresia? Right? So duodenum is not perfectly made. It is closed, right? Atresia. Stenosis, it means the narrowing of the duodenum is seen there, right? So as the duodenum is not having the near opening further, so the food will not going to pass there, right? If you are feeding this child, the 3 days old child, the food will be not passing further into the intestines, and due to this the patient is having the bilious vomiting. The child is having the bilious vomiting because the bile duct will be going to open into the duodenum. So till the duodenum it is normal, right? If the non-bilious was mentioned there and the single bubble sign was there, then what will be your answer, guys? The question is like that same only, right? There was a single bubble sign was there, है ना? एक single bubble sign भी होता है, right? So the single bubble sign was there and clearly mentioned non-bilious vomiting. What is the mention? They mentioned clearly non-bilious vomiting. What will be your answer, guys? Who guys are watching live, please try to reply in the chat box. Try to reply me in the chat box. I'm waiting for your answers. Very good, doctor. This is your pyloric stenosis. What do you mean by the pyloric stenosis? I will explain you here in this only, so it will be much easy for you. So we have the stomach pylorus. So this is your stomach, and stomach is having the pylorus part, which is the pyloric part will be going to attach to your duodenum. So if the pylorus will be getting stenosis, pyloric stenosis means the pylorus is getting stenosed there, right? So in the pyloric stenosis, you will see only the single bubble. Single bubble of what? Only the stomach will be going to sink. And in this case, if we're talking about it, if we are talking about it, your pylorus, in the pylorus part, if the pyloric stenosis will be there, so what will be the scene? There will be the non-bilious vomiting, because it is before your duodenum is already the, what is the your site of your stenosis? At the pylorus. So the pylorus, there will be the no bile duct will be not there, right? So the bile duct will be open into the duodenum. So in the case of your in the case of your pyloric stenosis, you will see the non-bilious vomiting, right? So please mark this keyword. If the bilious vomiting is there, there will be the your, and the double bubble sign is seen there. This will be the case of your, duodenal atresia, right? Or duodenal stenosis, you can say, right? Duodenal atresia or duodenal stenosis, right? Should we move forward? Very good. Let's move forward for the next question. The next question is in front of you. A 30-year-old male come with the hammer injury on the hand. Okay, so the hammer injury on the head there will be there, and the CT was done. The CT is done. What will be your diagnosis as per the seeing this CT image? So what you can see in the CT image, this is the case of your the image in case of your radiology, but the particular, if I'm talking about this MCQ, this particular MCQ is from your forensic medicine, the chapter of your forensic medicine, right? Try to reply. There will be the what? There will be the maybe contusions. They were epidural hematoma is there, right? Depression, skull fracture is there, or maybe cerebral hemorrhage is there. What is your answer? What is your answer, guys? Very good, guys. Very good. You all are you all are replying very well, right? And it's feel like that you already prepare for your exams, right? You already had this all the questions or the all this chapter very well, right? So you can reply very well this all the MCQs, right? And you will going to rock on this 6th July, right? Right? Okay. So you can see in this image what we can see. In this image clearly you can see this is your skull bone, right? So this white color part which is seen here, this is your skull bone, and you can say as the bony rim also, you can say, right? So this bony rim which is seen here, this bony rim is having the particularly, you can see this bony rim is having a depression here, okay? Not the separated, the bone is not getting separated, so we can say there, right? Bone is not separated there, just bone is getting depressed inside. Okay, the bone is getting depressed inside because of this is the blunt injury of your hammer, right? Hammer is in front of you, the hammer is your blunt, right? So as the hammer injury is seen there, as the hammer is seen there, so this is your depressed skull fracture. So what will be your answer? Depressed skull fracture. I think it's possible to, I will show you the image of depressed skull fracture, just a minute. So it will be quite easy to understand for you, right? Quite easy to understand. Also, it is seen more commonly seen in the your newborns also, right? What is the says what we are saying in the newborn? This particular fracture. Is there any another name of this fracture also in this particular name of this fracture? Can you tell me in the chat box, guys? I'm waiting for your answers. Yes, now you can see here. This is your depressed skull fracture. Can you see? Can you see this? What has happened in this image? What has happened in this image? See clearly. This bone is getting fractured. These fragments are getting depressed inside. Can you understand this area? Just identify this area only. Okay. So as the hammer injury is there, as the hammer injury is done there, so you can see as due to the hammer injury, these bones are getting depressed there, right? Okay. So this is your what exactly? This is your skull depression skull fracture. This is your depression skull fracture, right? Okay. So this is a scene in the your blunt injuries, and all it is seen in your newborns also. I know it is seen in your newborns also. Very good. Should we move forward? Right. So please understand the keywords. What was the keyword here? The hammer injury. The hammer injury is your keyword. And although your image, which is the image is given of the CT image is clearly given that there is a depression of this bone. Bone is getting depressed inside, right? So this bone is getting depressed inside. So this is your depression skull fracture. Depression skull fracture. Can anyone of you can tell me what will be the scene on your epidural hematoma? Anyone of you? What will be the clinical sign, radiological sign will be seen in your epidural hematoma? I'm waiting for your replies, guys. Okay. What will be the scene in your epidural hematoma? Okay. Right. I'm waiting for you. Yeah. Very good, doctor. Very good. In the newborns, we are seeing this ping pong fracture also. Very good. Ping pong fracture, right? And this is the due to in the normal vaginal delivery, maybe due to the any instrumental injury was iatrogenic, right? What is the mean of this particular the cause of this in the newborn? In the newborn, this depression skull fracture is due to the iatrogen. Okay. Very good, guys. Very good. Idli shape, right? Idli shape will be seen there. Okay. The idli shape will be seen there like that. The hematoma will be seen like that. But please remember, in the hematoma, only hematoma will be seen there in the dark color. And particularly in the question, they will surely mention the lucid interval. Very good, guys. They will surely mention you about the lucid interval. What do you mean by the lucid interval? What is happening in the lucid interval? Once as they had the injury, the patient has had the injury, the patients will be having the one unconscious phase, and after this conscious phase, the patient will come in unconscious to the patient will become a conscious in the conscious phase. And after this conscious phase also, again there will be the repeating of your unconscious phase, and this is particularly known as your lucid interval. This is known as your lucid interval. Of course, you can say the idli shape, right? The idli shape hematoma. But just remember this: why there is not the idli shape hematoma is not the answer here, because in the hematoma there will be the no bones will be not getting the rupture, right? So the bones will be the normal. If the bony cavity or the bony will be the, remember there exactly the period of the consciousness between the two unconsciousness. Okay, I already told you that once the patient will be getting after the injury, sudden the patient will be getting unconscious. Okay. Okay. So there will be the unconsciousness will be there, and after the unconsciousness, the patient will be again is having the one more conscious interval, and again with this conscious interval, the patient will go into the unconscious interval, right? So this is about your lucid interval. And where will be the more commonly seen your epidural hematoma? Where will be seen your epidural hematoma is more commonly seen? You can write it down like idli shape hematoma, right? Idli shape hematoma will be seen in your epidural hematoma. Can you tell me that what is the most common cause of your exactly patient is the completely level for the law in the lucid interval. Exactly, guys. Okay. Yeah, in the road traffic accident, this is the most common cause. Very good. The epidural hematoma is the your road traffic accident. RTA is the most common cause. Okay. Or the cricket ball injury also seen there, right? A part of the Patreon, right? Exactly, on the Patreon will be there will be the injury with the cricket ball, right? So you can write cricket ball injury where at the part of your skull Patreon. Okay, on the Remember this, Patreon. Which artery will be on the Patreon, guys? Which artery is the most commonly or passing through the Patreon part of the your head? I'm waiting for the name of artery also. Very good, guys. Middle meningeal artery. Very good. MMA. Very good. Mid-meningeal artery. Very good. This is the branch of maxillary. Exactly, right? So this is all about your epidural hematoma. Just one more. There is a subarachnoid hemorrhage is also there. What do you mean by this subarachnoid hemorrhage? Can you explain me about anything? What will be the clinical features will be seen? Any one of you? Any one of you? Why I am asking you? Why I am not replying you? Because you are near the exam, right? So I want the answer from you guys, right? How much you remember of it? Because we are doing the discussion of it, right? Already you had the session of your radiology on the app, right? You had the already radiology session on the app, right? So we are doing this now discussion. Okay. So what will be the scene in the subarachnoid hemorrhage? Very good. There will be the your thunderclap. You can say headache will be seen. The firstly, there is a thunderclap headache. Okay. What is the mean of the thunderclap? Right? As the thundering will be there, so there will be the more headache will be suddenly increasing and decreasing. Okay. So the thunderclap and also the hemorrhage will be seen in the between this arachnoid space right here. The bleeding will be seen, which will be your, you can say the intraventricular bleeding, right? So the thunderclap, headache will be seen there. Exactly, guys. Your intraventricular bleedings will be seen there. The bleeding will be between the ventricles. And also, the importantly, can you tell me the cause of the subarachnoid hemorrhage also? Anyone of you can tell me what is the most common cause? What is the most common cause of your subarachnoid hemorrhages? Okay. Anyone of you? Do you know about it? What is the most common cause of subarachnoid hemorrhages? Anyone? No one? Right? Okay. Hypertension. Okay. Your hypertension. Exactly. Exactly. Right? So there will be your subarachnoid hemorrhage. Hypertension is the most common cause of it. Right? And with this, you will gonna see the thunderclap. Yeah, falling in the bathroom can be seen. The rupture of your uh, aneurysms will be there, right? So due to the hypertension, there will be there, right? So there is the aneurysm will be rupture due to the hypertension, right? So this is the most common cause of our subarachnoid hemorrhages, right? So this is all about your MCQ, which is shown in this particularly. So you will cover your epidural hemorrhage also here, subarachnoid hemorrhage is also here, and please remember your depressed skull fracture. So this is the particularly your question which is mentioned. The CT scan was mentioned there. This is your this depressed skull fracture. Please remember, just the fragments are depressed there, not the separated, not the separated, just only depressed. And this is most commonly seen in your blunt injuries. Okay, blunt injuries like hammer. Okay, through this hammer. Okay, so this is most common seen in your blunt trauma of head. Okay, as I already mentioned you, this is seen in your most commonly seen in your blunt injuries or the blunt trauma of the head, right? So this is all about your skull, depressed skull fracture. Should we move forward, guys? I hope you are enjoying this session, right? As it is a quite easy and interesting subject, right? Radiology is quite easy and interesting subject for everyone, right? And it is more important that making our diagnosis in the orthopedics also. It is helping in the surgery subject also. It is helping in our medicine subject also. And FMT also. Just now we got the FMT MCQ, skull depressed fracture, right? So we covered with this also, right? Should we move forward? Okay, let's move forward for the next question. The next question is in front of your screen. Just let me know what you are seeing here. The 34-year-old male patient is there. Just a minute. Yeah. So there is a 34-year-old male patient come with a recurrent UTI, and the patient is having the left side flank pain also. So the mention there is a UTI is there. The patient is having the UTI, right? And also the patient is having the left flank pain. Due to this, we had the CT scan of the abdomen was done. CT abdomen was done, and we saw a sign on the CT scan. And they're asking you about the CT scan sign. They're asking about the Sure, sure, sure. We'll explain you all the questions, no issue. All the options we'll talk about it. What is important for your exam point of view? I will surely talk about the all the options which is given there. No issues, no issues. Okay, okay, sure. Okay, so what is your answer in this case? What is your answer in case? What you are seeing on this particular CT scan image, which is shown here. Now, this is your CT image, and the option is clearly given you. The first is your horseshoe kidney. The second is your polycystic kidney disease. The option C is your renal atropia, and D is your hydronephrosis. So hydronephrosis will be not the seen. In the hydronephrosis, we have to see the nephrons, the ureters also. So the hydronephrosis, the kidney will be getting enlarged there, but I cannot see the kidneys enlarged here. And what you guys can see here, exactly, your answer should be your horseshoe kidney. Your answer should be your horseshoe kidney. How you can see the horseshoe kidney? As I'm seeing this image, this is the right side of the patient. This is the left side of the patient, right? As the CT image is there, so this is the right side of the patient. This is the left side of the patient. And what I can see this is the vertebra. Okay, with the vertebra, out of this vertebra, as after this vertebra, I can see there is a kidney, and I can see here this is looking like that. I'm drawing it. I'm going to drawing it. This is looking like that. The horseshoe. How's the horseshoe is there? I think you know about it. I'm drawing here about the horseshoe also. So you will remember like that. So this is the horseshoe, right? You saw horseshoe, right? So it is looking like the horseshoe, right? So the name is given the horseshoe kidney. Now my question is there, what is the most common cause of your horseshoe kidney? What is the most common cause? Anyone of you can reply me? What is your horseshoe kidney most common cause? And please remember, this is your horseshoe kidney. This is your kidneys, right? So this kidneys will be going to join together. Please remember this, both of the kidneys are joined together anteriorly. Okay, from the anterior side, it will be going to join together, and it is on the CT scan. If we are doing the CT scan of it, so it is joined together. As it is joined already together, the both of the kidney, left kidney and the right kidney, so it will be going to see as a horseshoe shape, right? So the horseshoe kidneys is seen. The name of it, the horseshoe kidney. What is the cause of horseshoe kidney, guys? Anyone of you can reply me? I already asked you. What is the most common cause of your horseshoe kidney? Anyone of you? Anyone of you guys? It is a congenitally. Okay. Please remember, it is your congenital cause. The most common cause is the congenital. For by birth, if the patient is having the joining of this both are the kidneys, and this is the most commonly seen, the horseshoe kidney, right? So the horseshoe kidney, right? Remember this. The next option, if I'm talking about this, the polycystic kidney disease. I hope you know about this. Anyone of you can reply me, what is the scene in this polycystic kidney disease? What is the mean of this polycystic kidney disease? What will be going to see, and what will be the scene in your hydronephrosis? What is the most common cause of your hydronephrosis? This both of the options we have to talk about it. Now tell me your knowledge, guys. I'm waiting for your replies in the chat box. What do you know about the polycystic kidney disease, and what do you know about the hydronephrosis? This the both is also important topics, right? Yeah, it's a congenitally. Exactly, doctor. It is a congenitally. By birth only the patient is having it. It's not possible after the birth it will be going to join together, right? Right. So just due to the congenitally abnormalities, there will be the there will be the scene of your horseshoe kidney, right? Horseshoe kidney will be seen. Now tell me what about the polycystic kidney disease? What you know about the polycystic kidney disease and about your hydronephrosis also, right? So as the name is given, guys, you can see by the name only. If I'm dividing this name into the three part, poly, it means multiple, okay, or more than two. We can say poly, right? Cystic, it means a cyst, right? And the kidney disease. So it means in this particular polycystic kidney disease, what will be happen? We can see there will be the more and more cyst over the our kidney. Okay, so there will be the cyst will be clearly seen in there. Surely I will show you the image, radiological image of this polycystic kidney disease also. Just remember about it that in this particular disease, on the kidney, we can see there is a more over the cysts are there available on the kidney. So this is about the polycystic kidney disease. Talking about the hydronephrosis, by the word, again I'm dividing into the two parts. The word, first word is your hydro, and the second word is your nephrosis. So the first one is your hydro, it means the fluid, right? So as your fluid will be going to there, right? So the your fluid will be which fluid? Urine, right? So as urine will be going to pass there, if the obstruction in the urine, now understand the thing, if the ureter or maybe the gallbladder is having the obstruction, so the backflow of your particular fluid will be having the backflow, and this will be going to accumulate it into your ureter. So ureter will be getting dilated. In the hydronephrosis, what will be the scene? Your ureters will be getting dilated. As the ureter will be getting dilated, this particular, now this fluid as accumulates slowly, it will be going to accumulate it, so it will reach to your kidney also. The kidney will size will be going to enlarge, right? So this the hydronephrosis is seen in your obstruction. Okay, so in the case of obstruction, maybe kidney stone obstruction, maybe other obstructions will be there. So due to the obstruction, there will be the hydronephrosis will be going to see, right? Okay, exactly. We can see the multiple hypodense regions. Hypodense, it will be, yeah, the cyst will be seen as the hypodense. So on the particularly kidney area, we'll see the more over the round shape of the hypodense lesions. Exactly, guys. So I hope you understand this question also, right? It was quite easy and understandable for you. Please remember, this is a very important horseshoe kidney. This is a very important clinical image, and previous year already asked 2 to 3 times this question is asked in your FMG and NEET PG also. Right? So remember about it, right? So remember, this is a horseshoe kidney, and it is a congenital defect. As I already mentioned you that this is your congenital defect. Horseshoe kidney is your a congenital defect is there, right? Okay, let's move forward for it. Just a minute. Just a minute, guys. Give me a minute, guys. Okay, so this was the horseshoe kidney, congenital defect. I already told you this is your congenital defect. Okay, so we talked about the horseshoe kidney, and let's move forward for the next. Sorry for this disturbance, guys. Sorry for this disturbance. Okay, I think my screen is visible to you now. Okay, so we talked about this is your horseshoe kidney, about your question, horseshoe kidney. Okay, talking about the now the next question, we are moving forward for the next question. It's about your moving forward. So in the next question, they're particularly asking you the principle of your linear acceleration. They're asking you about the principle of your linear acceleration. They're asking you about the particularly question. The linear acceleration will be seen in which conditions? Just a minute. Yeah. So the question is asking you the principle of the your linear acceleration is utilized in the production of what? Which kind of the rays are going to produce by the utilizing the production of your linear acceleration. So I hope you know about the process of the making this rays, right? From the basic of your radiology, right? From the base of your radiology, you know about it. And don't wasting on this particular question. Please, I hope you already remember. And this is a repeated time question is asked to you. So this is about your X-rays. This is the question is about your X-rays. So your X-rays is having the principle. The X-ray machine is having the principle of it, right? So I hope you know about the X-ray machine also, right? So if you saw about the X-ray machine, if you saw and you know about their X-ray machine, so you saw this is having a particular principle on the running of it to making or the production of your X-rays, right? So it is having the linear acceleration. So what it is having? It is having your linear acceleration of it, all right? So about the X-ray, it is about your X-rays. Okay, so remember about it. This is the X-ray which is having the linear acceleration. And now understand the thing how it is making the linear acceleration. This is the acceleration of your electrons. So the electrons in your X-ray machine, they will do the accelerated in your linear process. Okay, so the linear way, it means a linear way they will going to accelerate it. So due to the acceleration in the linear way, they will be going to produce, they will be doing the production of or the producing the your X-rays. They will doing to production of X-rays. This is quite easy. Just remember about it. Just remember in a one point that this is the linear X-ray. The linear acceleration will be going to use in your X-ray production. X-ray production, right? Quite easy. Okay, theoretical questions. No image is given in the radiology, right? Okay. The next question: which radiotherapy treatment? So the question is related to your radiotherapy, and please remember out of the radiology, if I'm talking about it, the radiology is having as per the blueprint, it is having the 5 marks. Okay, the particularly the radiology is having the 5 marks. Out of this 5 marks, there's a 1 mark. Surely they're asking you about the radiotherapy. The surely and surely they will ask you about the any type of the question they can ask you on the base of the radiotherapy. So please try to cover the radiotherapy very well. Okay, and secure your 1 mark. Okay. So they're asking about the this question is from the particularly from the radiotherapy part. Okay. So in the radiotherapy treatment given to the cancer patients, as you already know, so in the cancer patient, and what they are doing, they are administrating of the dose of your 1.8 to 2 gray. I hope you know about it. The gray is the measuring the uh, radiation, right? Gray. So the 1.8 to 2 gray is given once daily. They are giving the daily. They are giving the daily 1.8 to 2 grays. They are administrating there and giving for the 5 days in a week. Okay. So in a 5 days a week, they are giving it. So over the period of 6 to 8 weeks, guys. So over the 6 to 8 weeks, they continuously, please understand the thing. They continuously, what they're doing, they're giving this radiotherapy to him. So what is the kind of this radiotherapy? Can you tell me? The options are given in the option. The A is your regular fractionated radiotherapy. Option B is your hyperfractionated radiotherapy. Option C is your accelerated fractionated radiotherapy. And the option D is your brachytherapy. Brachytherapy. Now tell me, as you can understand the thing, it is given as the regularly form. It means daily because they mentioned the word once daily. It means the regular form is there, so it is having the regular. And what do you mean by the fractionated? Fractionated, it means having the small amount of. What do you mean by the word of it? It is having the small amount. Okay, it is having the small amount. How it is the given? They given this particular radiotherapy in a small amount. Okay, so 1.8 to what to the 2 gray, 2 gray, 2 gray. It is a small fractionated. So the regularly fractionated radiotherapy. So the answer should be here your regular fractionated radiotherapy, right? So we are giving in the regular period of it and giving in the fractions, in the small fractions we are giving in the radiotherapy. Now, what is about your option B? Anyone of you can tell me what do you mean by the your hyperfractionated radiotherapy? Anyone of you can tell me what do you mean by the your hyperfractionated radiotherapy? Anyone of you? And important, which is the brachytherapy. They can ask you about the brachytherapy also from the radiotherapy. So we'll talk about this brachytherapy also. The first you will tell me about the your hyperfractionated radiotherapy. As it is also fractionated, it means having this small amount of the small amount of radiation should be given in this patient also, right? But guys, not the large amount. Fractionated, it means the small amount is surely there. Okay, hyper, it is more than one time. It means not the regular. It is like today given once, again now in the day also given again. The 2 doses are given in a day. Okay, so it is having the hyper one. Okay, and after that they will giving the gap of it, not the regular. They will not give the regular basis. It is not the on the daily basis. They will not give the regular basis. It is having the more than one fraction exactly in a day, right? Twice a day exactly. So they're increasing the amount of the small amount will be given, but the more time should be given. Okay, more than one time should be given. Now what about the brachytherapy, guys? What do you mean about the brachytherapy? It's also the important to from the question from the your radiotherapy part or the radiology part of the your radiotherapy. Tell me what do you mean by the your brachytherapy? What do you mean by the guys your brachytherapy? Anyone of you? Do you know about something about the brachytherapy? I think no one knows about it. Okay, so understand about it. In the brachytherapy, what we are doing, we are giving the particular this radioactive substance or this yeah, of course the brachytherapy is the radiotherapy part of the radiotherapy. Surely, doctor, it will be used in your treatment of the cancer. Okay, cancer treatment. So what will be doing this? As per the radiotherapy, it is giving from the outer sources, right? Now, what will we do? What will we do in this brachytherapy? We will give this source of your particular radiation, right? Which source will be going to produce the radiation, and will give this particular radiation source inside the cancerous cell. Okay, so like if I'm giving the example, the brachytherapy of the your breast cancer. So there will be the breast cancer. What they will do? or maybe any kind of the cancer. So in the cavity, they will insert a particular catheter, and through this catheter, they will give you the radio active substance. What they will give you? They will give you the radioactive. Yeah, source will be placed close to the tumor. Exactly. So the radioactive substance should be given, and this radioactive substance will be go inside and do this radiation. What it will do? It radioactive substance will be go inside to tell your tumor is reached to in the body in the tumor, and there they will do the what it will do the it will make the radiation. So this particular radiation will be going to affect the particular tumor because it is from the near the tumor only, and it is already inside the body. Okay, so it will give the more, it is having the more efficacy, or we can say the more effective work, right? So in the brachytherapy, the source will be placed inside the body. Exactly, doctor. So the source will be where? Your source of the making this radio waves or the radiations will be from your inside the body. So this radioactive substance should be placed inside the body. No. Okay. So this is also important. I'm writing here important. So please remember about your brachytherapy also. About your brachytherapy. So this is your regular fractionated radiotherapy, which I already told you. So 1 to 2 grays, 1.8 to 2 grays are given daily basis. As the MCQ is given as the 5 days of the week they are given. So the regularly fractionated they are given in the smaller doses than the regular fractionated radiotherapy. What we are doing, we are giving the smaller doses in the repeatedly. We are giving the repeatedly rather than a single large dose. Okay, so not giving a single large dose in a more grace is given into a single dose only. No, we are giving what? We are giving the very small fractionated, right? So that's why the smaller dose are given into the repeatedly type. Okay, repeatedly we are giving the daily, right? So that's why it is a repeatedly given. Okay, guys. So this is about your question from the radiotherapy. Very, very important questions. Please mark important about the radiotherapy. I already told you from the radiotherapy, one question surely will be there. Okay, because nowadays also you can see the cancer is more. So in the MCQ in your exam, they will surely ask you the question related to the radiotherapy out of the radiology subject. Okay, so one question from the radiology from the radiotherapy. Let's move for the next question, and this is asking you identify the rib which is shown in the X-ray. So they're asking about the rib which is shown on the X-ray. So I'm going to zoom in into this X-ray particularly, so it will be quite easy to remember or identify it. And I'm waiting for your answers. Anyone of you can reply me in the chat box which rib is shown here. The options are given. The option A is your third rib anterior part. Option B is your third rib posterior part. Option C is your fourth rib anterior part. And the option D is your first rib anterior part. I'm waiting for your answers, guys. I'm waiting for your answers, guys. As I already zoomed in this image clearly, so I think you can identify it more easier. Moreover, the easier. Okay. Anyone of you? Okay. Should I zoom in out? Okay. Let's zoom out this image. Come back to the question. Okay. Now, no one is replying. You guys are not replying in the chat box. What happened, guys? Try to reply in the chat box. Try to reply in the chat box. Quite easy question. Quite easy question. Okay. This is not the fourth rib, guys. This is not the fourth rib. This should be your third rib. And this is the part of the third rib, which is your posterior part. Which part is it? It is the part of your third rib posterior part. Now, how you can ask me? So let's zoom in again, and I can explain you very well. So you can see here, this is the rib number 1. I can make is the mnemonic of it. Rib number 2, and this is your rib number 3. Okay, your rib number 4 is here, guys. Okay, so this is your rib number 3rd. But out of the rib number 3rd, we have the two options. The option A is said anterior part of the rib number 3, and the option B is saying posterior part. So how we can identify which is the anterior or which is the posterior? How we can go to identifying this? The anterior is it or this is the posterior? So please remember, as this X-ray should be taken in the AP view. What is the should of the X-ray? Should be taken into your AP view, and in the AP view, your clavicle, you can see this clavicle is going to overlap Yes, overlap कर रही है नहीं कर रही है? You can see clearly this clavicle is doing the overlapping of this particular rib. So that's why this is your posterior part of your third rib. Okay, so as it is doing the overlapping of your third rib, so this is your surely on the CT, sure. Okay, about the X-ray, is it clear? About this question is clear, doctor? You are asking, sir, please tell how to identify structures on the CT. Okay, surely. I will show you the CT scan. Okay, in the later part, अभी हमारे पास आएंगे बहुत सारे CT scans. I will surely talk about your structures. Okay, which structure is in this particular CT scan. Surely we'll talk about it. Okay, we'll talk about it. Okay, it is depending on the which section you are seeing in the CT scan. Okay, if you are seeing on the brain level, so it is the different structures will be there. If you are seeing in the thorax, on the thorax also we have the different sections of it, right? So as you already know, the slices are given in the particular CT, है ना? So that's why we have to see in the which slice you are seeing. Okay, so there is a different structure will be seen on the different particular slices. Okay, so at which level you are seeing, the structures will be seen on that particularly. Okay, so you can see, I hope this question is understandable for you. Please remember, this is your third posterior. What is the rib? This is your third rib of the posterior part. Quite easy question, quite easy question. And remember with this, right? This is a question from your X-ray imaging, right? To identifying the image of X-rays. Okay, this question is from your imaging, X-ray imaging. Okay, let's move forward, right? Explaining you, this is the X-ray of your AP view, as I already told you. Antero-posterior view, you can say. This is the X-rays having the view, right? Oblique view, lateral view, having the antero-posterior, posterior-anterior, right? AP, PA, both of the views are there, right? So this is related to the views of your X-rays. And this is the rib, which is the high and your superimposed on the clavicle. This is the important thing. This is the superimposed on the clavicle. So that's why this is your posterior part of your third clavicular, right? Or your third rib. Okay. This is the superimposed on your clavicle. So this is your third rib posterior part. Third rib posterior part. Very good. Let's move forward for the next question. Very important question from your emergency subject. You can say the, not the subject, you can say like from the emergency, right? If you're working in an emergency. So the which of the following is the whole CT, your whole body CT scan protocol? So they are asking about the whole body CT scan protocol for the trauma. For the trauma. Okay. Patient is not included. Please, guys, please try to understand the things. When you are sitting in the exam, what is happening? Little bit stress is there. Okay. And you are a little bit panic, or maybe you are a little bit in a hurry. You are not reading the words not accepted and not included, like some small words. Okay. Or accept this, right? So please try to identifying this particular words first of all, and then try to answer it. Okay, don't do in the hurry, don't do hurry. Okay, so please try to, so they're asking you not included. Okay, so we have to answer the not included, which is not included in that, right? And particularly they're asking you what, they're asking the whole body CT scan protocol of the trauma, right? So as the trauma will be there, if there is a RT is there or any trauma will be there, so what is the protocol? The CT scan, whole body CT scan protocol is there, and it is having the 4 important CT scans of there. Okay, so which is not included out of this? Can you tell me? Option A saying CT head, option B is the CT cervical spine, option C is your CT limbs, and option D is your CT abdomen. Now anyone of you can tell me? C, okay, everyone is replying CT limbs. Exactly, very good, I agree with you. Now anyone if you can tell me, I agree with you, this the answer is the CT limbs only. Why the CT limb is not included? As the trauma was there, the trauma was happened to the limbs. Now tell me, if the trauma is related to the limbs, why we are not doing the CT scan of that in the protocol? CT scan for all body CT scan protocol. Why we are not doing any CT scan of the limbs, guys? We are doing the CT head, CT cervical spine. We are doing CT abdomen, and one more is included in your. The next question is that only, that which if limb is not there, the 4 total CT scans are there. So which is included in your protocol of your trauma of the CT scan protocol? Can anyone of you? Please understand the limbs. If the limb is having the any trauma or any fracture will be there, it is not the life threatening. The first of all the things is there. Okay. It is not the life threatening. So that's why, yes, as a severity will be there, we can say the severity, or you can say the not the life threatening. Okay, life threatening nahi hoga. If the limbs fracture is there, or the bone is getting fractured, the limb is getting fractured will be there. So this is not going to be the life threatening. Okay, if the CT had is the important, we have to see there will be the maybe there's a hemorrhages will be there in the brain. We have to identify about the hemorrhages. So this is a very important. Although we have to do the CT cervical spine, we have to see about the spine. The importantly, in the trauma or in the road traffic accident, we have to see the cervical spine, right? Spine injury will be there or not. The next is your CT abdomen. Why we are doing the CT abdomen? Because due to the injury or due to the your trauma into the road traffic accident, there will be the more hemorrhages or the rupture of your aorta in the abdominal aorta, right? So abdominal rupture of your abdominal aorta, or maybe the hemorrhages will be the, or maybe the rupture of the arteries, the bleeding will be the more common. The hemorrhages will be the, your abdominal hemorrhages will be the more over the common. So that's why we are doing the your CT head, CT cervical spine, CT abdomen. Which is the fourth one? If the CT spine is not there, this is not there. Okay, this is not including in that. So which is including in that? The third one or the fourth one is included here, your CT pelvic. Okay, please remember your CT pelvic should be done in the your protocol of your CT. Okay, so I will mention you that. So please remember your CT limb is not in the protocol of your whole body CT scan in the protocol of the trauma. So what is included? Please remember your whole body CT, your whole body CT scan protocol of the trauma is including. The first is your CT head, the option 2 is your CT chest, option 3 is your CT abdomen, and option 4 is your pelvic CT. In the from the chest one will be going to cover of your spine, cervical spine also, right? So the head, chest, abdomen, and the pelvis CT should be done into the cases of your trauma. Okay, so this is about your whole body CT scan protocol of the trauma. Okay, remember this. This is the very important question. Okay, let's move forward. Moving forward for the next question, they are asking about your Hammond sign. Hammond sign seen in which condition? They are asking you about the Hammond sign. Now, first of all, anyone of you know about their Hammond sign? Please let me know in the chat box. What do you mean by the Hammond sign? Then we'll talk about it within which condition we are seeing this Hammond sign. Anyone of you? Anyone of you guys? What is the mean of your Hammond sign? The Hammond sign is seen in which condition? Or with seen in out of this which is given here mentioned in the list, in which condition the Hammond sign we should be seen there? So first of all, anyone of you can tell me in the chat box what is the Hammond sign? Guys, what is this your Hammond sign? Any one of you? Any one of you guys? No one? Okay. Okay. Snow sound. Okay. Snow sound. Crunching sound. Very good. Snow sound is there. Crunching sound is there. Walking on snow. Very good. Walking on the snow sound. Very good. It's kind of the crunching sound. Okay. Crunchy sound. Very good. So out of this, in which condition will be seen? It is seen in your pneumoperitoneum. It is will be seen in your option B is your pneumopericardium. Option C is mentioning your pneumomediastinum, and option D is your hydropneumothorax. So by this particular thing, the hydropneumothorax should be the not the option. As the hydro, there will be the seen, the dull sound will be the seen, right? Or bubble sound should be seen there, not the crunching of the sound. The crunching sound will be not the available. This is the main thing. Now, out of this, where will be the scene? Of course, your answer should be your pneumomediastinum. So what do you mean by the pneumomediastinum? Now, first of all, tell me from your anatomical knowledge, what is your mediastinum, guys? What is your mediastinum? I'm waiting for your answers in the chat box. What do you mean by your mediastinum? What do you mean by your mediastinum? Waiting for your answers, guys. Please try to reply. Who are watching live, please try to reply me in the chat box. It will be quite easy for me to understand that how much you know about it. Okay. Okay. So mediastinum is in your behind the sternum. We have a particular cavity will be there, which is known as the anatomically we know that's the mediastinum. Okay. We have the mediastinum. Okay. So this in the particular this mediastinum, there will be the air will be going to accumulate. That's why the pneumo it means the air. Okay, so air will be going to accumulate it there, and here of course your answer should be here pneumomediastinum. Now we have to talk about the Hammond sign. So about the Hammond sign, if I'm talking about the Hammond sign, yeah, you can say like that space between the lungs behind the sternum. Exactly, I told you the behind the sternum we have the mediastinum, and we have the mediastinum is also divided in the further parts. Okay, very good guys, very good guys. Okay, so this is seen in the particularly seen in your pneumomediastinum. Where it will be going to seen? It will be seen in your condition of the pneumomediastinum. Now talking about your Hammond sign. So what is the mean of your Hammond sign? Your Hammond sign is seen in the your mediastinal crunches. Okay, so it is a crunchy voice. Okay, the sound will be going to your on your auscultation with the stethoscope when you are listening this particularly. So what will be you are listening a crunching sound. What kind of the crunching sound? Like your crunchy, what is the meaning of your kukure or whatever you are eating? So sometimes the crunchy voice is coming like that. So that particular crunchy voice will be there. Although you can say like that one doctor is mentioning they're walking on the snow. So as the snow will be there, if you're walking on the snow, okay, so it will be also having a sound of it. Okay, so crunching sound is seen, listen there. So this is a particular the mediastinal crunches. Okay, in the Hammond sign, and this is the okay. Kindly increase the please. I didn't say what you want to say, doctor. Okay, so this is a mediastinal crunches which is heard into your auscultation, and we are setting in the. It is particularly seen in your mediastinal emphysema. What is the meaning of emphysema? Air in your mediastinum, which is also known as your pneumomediastinum. Okay, so the Hammond sign is your seen in your pneumomediastinum. So the image I shown you here, I think I will show you the image of pneumomediastinum also. So maybe they can ask you directly by the image. They can show you the image of this pneumomediastinum, and they can ask you about it, that which sign is seen in this. So you have remember the Hammond sign. You will be remembered there, right? So you can see here the what is the meaning of pneumomediastinum, as I told you, behind this sternum. So we have the here the sternum, just behind the sternum. You can see here this is the air accumulation in this area. Okay, so the air accumulation with this area, it is known as your pneumomediastinum, right? And also you can see here this is the blackening of here. So there's a small apical pneumothorax is also seen in this particular case, right? In the case of this particular image which I shown you, and also there is some surgical emphysema is also seen. Okay, so don't remember this, but we have to remember about the Hammond sign. So the Hammond sign is seen in your pneumomediastinum. So this is the clinical or the radiological image of your, this is the particular radiological image of your Hammond sign. Okay, so I hope you remember now about the Hammond sign. Okay, so this is about the mediastinal crunches of your Hammond sign. Okay, should we move forward? Should we move forward? Let's move forward. Now, the next question is in front of you, and identify the section of the intestine shown in this barium swallow. So we have to identify this particular structure which is mentioned there, which is the arrow is showing to you. They're asking about this section. Now, first of all, tell me about this. What is the meaning of your barium swallow? What do you mean by the barium swallow? Let's leave about this MCQ. We'll talk about this MCQ also. Just first of all, tell me what is the meaning of your barium swallow? Also, you know as the barium meal. Okay, barium swallow or barium anima is also there. Okay, we have to talk about this barium meal, barium swallow, barium anima, right? And things left, barium swallow is there, barium anima is there, barium meal is done. Okay, anyone tell me about this? What is the barium swallow, barium meal, and barium anima? Anyone of you guys? Okay, please remember the barium is your contrast material. Okay, the contrast material. What is the meaning of a contrast material? It will be clearly visible on your X-rays. Okay, so the barium is clearly visible on your X-rays, right? So what we are doing in the your barium meal, we are giving this patient to the barium in a kind of a meal, in the solid form, okay, to eat it, okay, and it will take time to go to pass through your stomach, then come into the duodenum, jejunum, ileum, and then your in the colon, and then passing through this rectum. It is taking too much time. Although then we have the barium swallow, and this barium swallow we are having a liquid type, okay. We are having this barium swallow, we have the barium into your liquid, and right, so the patient have to drink this barium. So this liquid part will be going to into your abdomen. Again, the same part, it is done for your GIT scan, okay. So what we are doing, we are doing the from this barium, particular barium studies we are done for your GI tract, okay. So for the doing this GI tract के लिए हम लोग करते हैं barium studies, right? So this barium swallow will be, the patient will be going to drink this barium, and it will be going to your passing throughout from this particular in the whole your GIT organ. The last one, which is from the anima, right? Barium anema. It should be the barium should be not drinking or eating. The first of all, in the meal and the swallow, it through from starting from the where it will be going to starting from your it will be going to starting from your esophagus, okay? Esophagus, then stomach, like that. But in the barium enema, we are giving this particular barium. We are injecting from the where we are injecting from the lower side from your rectum. Okay, so we are injecting or we are entering this this barium through the rectum, right, and doing the imaging of it. So this is about your barium studies, okay. So this whole barium studies should be done for your particularly for your gastrointestinal tract imaging, right? So out of this barium imaging, as I shown you now the barium images, now tell me in which which particular area is annotated here. This is the ileum, or maybe this is the transfer colon, jejunum, or your splenic fracture. So I am zooming in this doing the zoom in this particular image. So I think it will be clearly visible to you. Now, can anyone of you can tell me about from the options, option A, B, C, what is your answers, guys? I'm waiting for your answers. Try to reply in the chat box. What should be your answers? What should be your answers? Yeah, and remember from the rectal part. Exactly, guys. Okay. Swallow for the colon. Yeah, you can do the swallow for the colon, right? Barium follow through. Exactly. We have to take the X-rays of that particular patient, because X-rays your radio sensitive. So on the X-ray, we can see the your particular the the thing is here. Without the barium, if we're taking the X-ray of your GI tract or your abdomen, this X-ray will be not giving us the imaging of the our intestinal tract, right? So for doing this visible on the X-ray, we are giving this additioning of this your contrast, right? So this is your C, exactly. This is the your jejunum. What is this? This is your jejunum, guys. Exactly, very good, guys. This is your jejunum. So what is the mean of your jejunum? Can anyone of you tell me from your anatomically what is the jejunum? The jejunum, after your as your barium will be coming to their stomach, you can see here it is in the stomach, and from the stomach this is the pylorus part will be going to down into from your duodenum, and after the duodenum it will be going to pass through here. The duodenum will be the more superficially and the above of it, and the lower side of the right side, if I'm going is this is your jejunum. This is your this is your jejunum. Okay, this is what this is your jejunum, right? So this is about your barium studies. So please remember about the barium studies very well. This is a very important about your barium studies. Okay, so the barium swallow, barium meal, and your barium anema, right? Remember about this three particular barium studies. Let's move forward. Okay, let's move forward. So this was your jejunum, and as you already know, the barium swallow is your procedure to visualize your gastrointestinal tract. I already told you we have to do the GI tract. Okay, for the GIT, we are doing this particular barium studies. Okay, so barium studies should be done for your GI tract. Okay, for the GI. This is not the question from the particularly we can say from the your radiology, but it can be asked through as per the showing you the image of the your X-ray. But the X-ray image was I think not understandable for you very well, so I given you the clear-cut image, and they are asking about the which type of pelvis is shown to you. Which type of pelvis is shown to you below? So this is the which type of the pelvis, and option is already given to you. All the four options are there, which is your type of your pelvis, guys. The palletoid, Your B is your anthropoid, option C is your android, and option D is your gynecoid, right? So from your gynecology, obstetrics and gynecology, OBG, I think you had done this particular topic very well to identifying this types of your pelvis, right? So you are answering. Try to answer it. I'm waiting for your answers. Very good, guys. You are answering well. Okay. Just a minute. Please think about it. Your answer is perfect, guys. Android pelvis. Now just tell me how you identify this Android pelvis is there. The thing is, you have to reply me that this is how you identify this, that this is your Android pelvis. Now, can you tell me the clinical feature or the keywords? It will be much better for you to remind, because this question can be overlapping your obs and gynae subject also, and overlapping your particular your radiology subject also. Okay. So can anyone of you? Very good. Heart shaped pelvis. You can say the heart shaped pelvis. You can see here. This is particularly looking like that. This is having a heart shaped pelvis, having a heart shaped pelvis like that, you can see. Okay, so this is the particular heart shaped pelvis. Okay, so this is the heart shaped pelvis, most commonly seen in your male patients. Very good, having in the male patients. Okay, very good. So this is about your obs and gynae. Yeah, males have to the heart shaped pelvis too, right? Very good. Okay, so this is the heart shaped pelvis, and you, after the saying in the heart shape, you will understand this is the which kind of your, this is your android, this is your android pelvis. Okay, boys always have the good hearts. Of course, you can make a mnemonic of like that. Okay, boys always have the good hearts. So this is the male pelvic, which is your android type of the pelvic, right? Android pelvic. Okay, right? So the answer is your C, which is your android. Android. Okay, very good. So talking about your android pelvis also, I hope you remember from your obs and gynae, but I'm revising it. This is the type of the pelvis which is the beer more resembles, more resembles to the male pelvis. It is the more resembles to the male pelvis, and it is having what? It is having the narrow, than it is having the narrowed than the your gynecoid pelvis. It is narrow than the your gynecoid pelvis, and it is shaped more like a heart or wedge. Okay, so the heart shape and the wedge shape, it will be your, it will be your android pelvis, right? So remember about your android pelvis, and again remember this. This is having a shape of your heart. Again, I'm drawing here, so it will be remember for you. Okay, so drawing a heart here, so you can see here, this is your heart shaped pelvis, right? So this is your android pelvis. Remember about this. Okay, very important. You have to know about the all others also. I hope you already revised this into your obs and gynae, so I'm not taking it more deeper in this particular question. You already had this particular very well in your obs and gynae, right? So remember about the gynecoid, anthropoid, and your pyltoid also. Okay, let's move for the, your next question. And next question is in front of you. There is a 2-year-old child brought to the emergency room and experiencing in the speech and the breathing difficulties. The X-ray shown below. The X-ray shown below. What should be the treatment? What should be the treatment? So you can see in front of you, there is a foreign body in this patient's. You can see here, and although I'm adding one more image here to identify, or the clearing, the thing is here from the anterior side, the image of the anterior side. So it will be quite easy to understandable for you, that you will never ever confuse about it. I'm adding one more image, guys. Just a minute. Yeah. Now the question will be getting perfect or understandable for you. So this is your lateral view is also given there. Okay. So the lateral view is also given to you, and the your anterior view will be also given to you. Now, the please understand the 2-year-old child. Of course, he swallowed a coin. You can see this is the coin. This is the coin which is shown you. This is the coin which you can see here. Very good. So the coin had the foreign body ingested. The boy is had the having this. And also the patient is coming into your emergency room as having the speech. Guys, please understand, having the speech and the breathing. And this is the patient and this is the examiner's trick to confusing you, right? As you are thinking, the patient is having the speech problem, also having the breathing difficulties. So the patient will be having this coin into the which into the esophagus or into the trachea. I'm asking again this question as a one liner. If this kind of image is shown to you and they ask you in which particular anatomical structure the coin is in your esophagus or coin is in your trachea. Can anyone of you can tell me? Trachea or esophagus? Reply me in the chat box. I'm waiting for your answers. Reply me. Reply me. I'm waiting for your answers, guys. Waiting for your answers. As you see this image, can you reply me that where is this coin? In the trachea or in the esophagus? Okay, let's zoom in. I'm doing in the zoom in. This is your AP view of it, and this is your lateral view also. You can see the lateral view also. Can anyone of you can tell me it is in the esophagus or in the trachea? We'll talk about the question also, guys. Just try to reply me. A trachea. Okay, one doctor is replying about the trachea. What about the others? Okay, esophagus. Okay, now check it out. Now check it out. As I'm showing you the lateral view is better for to understanding this. That coin is in which area? Okay, and I will tell you about your anterior view. If anterior view is given by the examiner, so it will be not confusing for you. I will also answer you about it. Okay, as the patient is having the breathing difficulty, I understand for you doctors, the patient is if having the particularly the foreign body in the trachea, the patient is having more of the coughing reflex will be there. So the patient is not having the coughing reflexes mentioned there. Just the patient is having little bit difficulty in the breathing. Okay, right? Okay. Esophagus has the O, so it is in the AP. It will be okay. Now understand this thing. I'm showing you. So you can see as this is the image of the lateral view. You can see this is the your windpipe, or you can say the larynx. And after the coming here, it is divided into the esophagus, which you can say the pharynx. After the pharynx, it will be your oropharynx, and it will be the laryngopharynx. And you can see this laryngopharynx is having the totally black color air is passing through the down to the trachea. Okay, so as I'm clearly seeing here, again I'm erasing it. This red color mark which I made here, I'm again erasing it. Can you see this black color air as our particularly as I'm telling you, as our trachea esophagus is having the passing of the air, yes or no, to the lungs. So it will be going to pass through the your esophagus and trachea quite easily. You can see it is passing on the x-ray. It's clearly seen to you. That this is passing clearly. So it means the coin is not into their trachea, and it is behind to their trachea, and it is just behind to the trachea and the anterior to the vertebrae. Okay, anterior to the vertebrae and just behind to the trachea. So this coin is where the coin is in your esophagus. Okay, where is the coin? Your coin is in your esophagus. Okay, guys. Once again, this was about your image of the lateral view, but again, I'm going to show you from your anterior view also. So you will be not getting confused in the anterior way also. Now you can understand from this anterior view. This is the same particular patient's view or the X-ray of it. And now here also you can identify by this that this is the coin is situated here. This is the coin, but you can see behind it you can see I'm highlighting it this color black. This black color air is coming here, and you can see it is going through the trachea also. If this is visible to you, it means the coin is not in your trachea. The coin is not into your trachea. The coin is where? The coin is in your esophagus. And yes, of course, if I'm telling you about it, the speeching in your problem in the speech and the breathe, because the coin is foreign body is in your esophagus. So the esophagus will be having a little bit pushed the forward to their larynx. the patient is feeling sometimes the breathlessness or the breathing difficulties or the speech difficulties, but the patient is not having the coughing reflex. If they mentioned here the coughing reflex and we can see that this particular black line is not visible to you, so that will be the particularly in your larynx. So in the case as it is in the esophagus, so what we'll do, we're gonna do the esophagoscopy. What will we gonna do? We're gonna do a esophagoscopy. Now what do you mean by this esophagoscopy? Now everyone who was watching live, just give me thumbs up. This question will be not going to wrong in this exam if they are giving you. Did you understand about this, or any confusion is there? If you have any confusion, please write in the chat box. Okay, if you have any confusion, just write in the chat box. I will going to explain you easily. This is a question from particularly from the ENT. Okay, this particular question is from your ENT subject, right? And moreover, we have to talk about the radiology because the radiological imaging is there. So we have to talk about the radiological imaging. Is it understandable for you? Give thumbs up in the chat box. So I will understand this thing. Yes, you understand this particular topic. So I will move forward for the next question, right? I'm waiting for your thumbs up. I'm waiting for your thumbs ups in the chat box. Okay, very good. Okay, okay. So ये question गलत नहीं होगा, right? So we have to do the esophagoscopy. Now tell me, what is the meaning of esophagoscopy? It is an instrument through this where we are doing this esophagoscopy. We are doing in the some esophageal diseases also to identify this, and also from the taking the some biopsy from the esophagus for the identifying the some diseases. We are taking this. This is the instrument which is having the particularly uh, particularly is having a camera also, and the light is also available there. So we are putting this particular device into their esophagus, and through this we can remove this foreign body also. We can take the biopsy also, and the clear visualization of your esophagus is seen, right? Yeah, esophagus foreign body will do the esophageal uh, esophagoscopy. The tracheal foreign body surely will do the Hamlish maneuver and the laryngeal scope. Exactly, exactly. Laryngoscope. Hamlish maneuver should done in the trachea, will be the Hamlish maneuver will be done. Okay. Yeah. The laryngoscopy should be done in the larynx. If it is stuck into your larynx, then only do the laryngoscopy and remove it. Okay. Hamlish maneuver you can do, like laryngoscopy should be done into your hospital. Okay. Done by the doctor, not done by the you. Hamlish maneuver is a kind of an emergency condition. If you are seeing the patient is having the stuck of any foreign body, or maybe some food particle is gone into the your trachea or into the larynx. Okay, so into the larynx, so you have to perform the Hamlish maneuver. The Hamlish maneuver for the adult is different, for the child is different, right? So you have to do the Hamlish maneuver. It is a life-saving maneuver, right? It is a life-saving maneuver, right? Okay, so this is about your esophagoscopy, which should be done in this particular question, right? So this, the coin is in where? The coin is in this question, the particularly in the esophagus, right? So we have to do this in this particular clinical scenario. We have to do the esophagoscopy, right? Let's move forward. What is the esophagoscopy? Your esophagoscope, you have an instrument which is known as your esophagoscope. It is a very thin tube-like structure, or the tube-like instrument is there, and we have to pass this instrument. It is having a light and have a lens for viewing, or you can, what is the meaning of lens? Yes, kind of a camera will be available there, and it is also having a tool to remove the tissue, right? To remove the tissue or remove the foreign body also. If the foreign body is there, like this coin was there, so we can remove the foreign body, right? So this foreign body can be removed through this esophagoscope. Okay, so this will be the removal for the foreign body, or if any tissue will be there, so we can remove the tissue also to check the microscopic sign or the for the diseases, like in the Janker's diverticulum. In the Janker's diverticulum, you have to see, there will be the, we have to see the esophagus also, right? And also we have to see the, in the cases of any esophageal cancer will be there, so we have to take the biopsy of it. Okay, so for the taking the biopsy or removing this foreign body, or removing of the any tissues from the esophagus, we have to do the esophagoscopy. We have to do the esophagoscopy. So I hope you remember now this, and this is your previous year question, right? This is your FMG previous year question, so you have to remember about it. Okay, all right. Let's move forward. For the next, let's move forward for the next question. And the next question is very, very important in front of you. What is the diagnosis of the provided image? Particularly, they are asking you about the diagnosis of it. They provided you image and they're asking you about the particularly diagnosis. So you have to make the diagnosis just on the basis of the radiological image. No any clinical scenario, symptom, sign is not given to you. And the options are given here. Option A is your multiple myeloma. Option B is your ankylosing spondylitis. Option C is your pyogenic spondylitis. And option D is your pot spine. As you can see, this is the X-ray of your spine. Right? You can see this vertebrae are there. And this is your intervertebral disc space is seen into you. Right? So, anyone of you can reply me? I'm waiting for your answers, guys. What you guys can see here. If you want, I can zoom in this images. Okay. I can zoom in this images. Okay. So now you can see very well this image. So tell me out of the options I already told you. Okay. Many of you are saying the B, some of you are saying the D. Okay. So as you can see here, what I'm seeing on this particular image, on the particular image I'm seeing, there is the destruction of this particular vertebra. Can you see this vertebra is getting destructed? Okay. So there's a particular destruction. Okay. Destruction of your vertebra. And not only the vertebra, with this vertebra, as these vertebrae are getting destructed, there will be your intervertebral disc of your L1. Okay, so L1 and L2, this will be your L1, this will be your L1, and this is your L2. So the intervertebral disc space, the space between this L1 and L2, this is all also getting the depressed will be there, right? And you can see here also this one. So this is the total, there's the destruction will be there. And also we can see some exudates is also there. Not only this, we can see there is an exudate is also seen there. This exudates are also seen there. So what is this condition? Exactly, guys. Very good. Very good. This is your pot spine. What is this, guys? This is your pot spine. Okay. So this is your pot spine. Okay. What is the mean of your pot spine? Let's talk about it. Let's talk about it. What is your pot spine? Pot spine is your commonest extrapulmonary manifestation of your tuberculosis. Okay, guys. So you can say as the pot spine is also seen in your TB spine. Okay, you can say as the tuberculosis in your spine. Okay, TB spine. You can say as the TB spine, right? So this is your pot spine. Also, you can say as the TB spine. Okay, and this is spread through the hemorrhages route. So if you're talking about the metastasis or how it will be going to spread this TB from the extrapulmonary manifestation of the TB. So this is the hematogenous route. Important part that this is the how it will be going to separate is going to be the hematogenous part. And with the hematogenous part, there was a clinically, if we're talking about it, it will clinically present with your constitutional symptom like back pain. The patient is having the back pain, and sure, I will show you. Okay, the patient is having the tenderness, and the patient is having the paraplegia. What is the mean of your paraplegia? Anyone of you guys can tell me? What is the mean of your paraplegia? Question mark is there. Please reply me. I will surely tell you. You guys are asking, sir, side by side, show us about the ankylosing spondylitis also image, right? So you will be get to the differential diagnosis of both of it. Surely I will show you. Right? So just tell me what is the mean of paraplegia, or the can be seen your paralysis. Okay, and there is a capnotic and the sclerotic deformities are seen in your Pott's spine. So the Pott's spine is the cause. What is the cause of your Pott's spine? The cause of your Pott's spine is your TB. The most common cause is your tuberculosis, right? So ankylosing spondylitis X-ray I have to show you guys, so you will remember about it. You will not going to confuse between this both of the images, right? Yeah. Exactly. There will be loss of the motor movement on the one side. Paraplegia. Very good, doctor. Okay. So let's check it out here. This is the port spine, and I'm showing you the your image of your ankylosing spondylitis. So this is the image of your ankylosing spondylitis, AS, and this is your PS. This is your port spine. Okay. So now you guys can understand this thing. Now you guys can understanding this on the simultaneously you are seeing this both of it. Can you see here? Can you see here in the image of ankylosing spondylitis? I'm zooming in it. Can you tell me, is there anything? Is there anything in the destruction of any vertebra is given there? Can you tell me? Can you tell me there is the any kind of any kind of destruction of your any kind of destruction of your vertebrae are seen there? You can see the all the vertebrae are looking like a normal. Yes or no? All the vertebrae are having the normal, right? So vertebral destruction will be not seen on the your particularly on your image of your the X-ray of your ankylosing spondylitis. Rather than I'm comparing to you with the your port spine, you can see the port spine is having a particular destruction of your this particular destruction of your vertebra is also there. How the why the paraplegia is there? Because of the destruction of this particular your destruction of your the destruction of your particular vertebra is also there. So the nerve which is passing out from there, like I given you the L1 and L2 is having the passing of your nerves, and it will be going to supply to your lower limbs, right? So in the lower limbs, this will be going to cause the loss of movement there, right? Okay, yeah, okay. So there will be the you can see there will be the if you're talking about it, you can see here the this is your intervertebral disc, and here the intervertebral space is getting less. Okay, all the vertebrae are having commonly like that, and not having the intervertebral disc more. Okay, and but there is a no destruction. Is the destruction is seen there? No. There will be the in the ankylosing spondylitis. There will be the no destruction will be seen on the your on the on the your side of on the side of your on the your vertebrae. Okay, so I hope now it is clear to you. The both of the images comparatively I shown you that this is this your POTS spine. The second is your ankylosing spondylitis. All right. I hope it is clear to you. Give thumbs up if it's understandable for you about the POTS spine and about the, your ankylosing spondylitis. Give thumbs up in the chat box. We'll move forward. Right? Just tell me, give thumbs up in the chat box so I will understand about it. I will understand about it that you understand very well about this particularly. Okay, right? So this will be the comparatively you can see here, right? Very good. Should we move forward for the next question? Okay, let's move forward for the next questions. Okay, and remember about the your POTS spine is having the TB. Okay, which is your extrapulmonary manifestation. Okay, not the pulmonary, it is the extrapulmonary. Okay, and it is also known as the TB spine. And a POTS spine is also known as the TB of spine. Okay, tuberculosis of your spine. Very good. Let's move forward. The next question is seen in front of your screen. Let's little bit increase the size of this image so it will be quite easy for understandable for you. And this is a very important question for you guys. Very important. I'm again mentioning here important. Many times repeatedly they asked you about this question. And what is this question? There's a chest X-ray shown below. What will be the diagnosis? They're asking you about the diagnosis and they've shown you the image of it. And the options are given here. Option A is your bronchogenic carcinoma. Option B is your mesothelioma. Option C is your metastasis. And option D is your pneumoconiosis. I'm waiting for your answers, guys. And with the answers, I need one thing. Which sign is seen in here? Important is the clinical sign is which is shown you on this particular image of your X-ray. This is your X-ray image. Okay. So what you guys are seeing in this X-ray image? What you are seeing in this X-ray image? So tell me about this about the particular image sign. I'm waiting for your sign also. Okay. Some of you are saying the bronchogenic carcinoma. Okay. Agree. Okay. Some of you are saying the metastasis is there. Okay, I agree with it. So which particularly the scene, very good. Okay, I'm zooming in. Okay, I'm zooming into the images, so it will be quite easy and understandable for you, as it is. I'm zooming in. Now now tell me, what is your answers? Now tell me what is your answers, guys. Yes, very good. I got it. I'm getting the answers from all of you guys. This is a cannonball appearance. What is the name of this particular appearance? This appearance is known as your cannonball appearance, right? And you can see it is looking like the some cannonballs are there. The round shape of this cannonballs are there in the your thorax region, right? In the your thorax region. Very good. The cannonball, and you already know, that the cannonball appearance is seen in your metastasis, right? In the metastasis of your cancers. Okay, so metastasis of malignancy cancers to the your lungs, right? Lungs to the metastasis to the lung, it is shown you the cannonball appearance. And now, can you tell me the most common? Very good, guys. Very good. The most common pulmonary metastasis of your endometrial TB also. Very good. Endometrial TB is also there. What about any other? Can you name me about the any other cancers which can be metastasis to your lung and showing you the your cannonball appearance? Can you see? This is your cannonballs. Small, round shaped structures are there. This is your cannonball appearance. Okay. Any one of you? Any other which metastasis will be seen there? So this small balls are seen which is there. This is your cannonball appearance, and please remember the cannonball appearance will be seen in your kind of metastasis. Okay, so the metastasis, what do you mean by the metastasis? The cancer or the disease will be having on the other particular part, but it is now transferred to the your lungs. It is shown you the metastasis of it. Okay, metastasis of it. Very good. So this is the particularly cannonball appearance will be seen in your kind of metastasis in the cases of the metastasis. And please remember this cannonball metastasis refers to your this cannonball metastasis or the cannonball appearance is refers to your multiple large well circumcised. There is a well circumcised round pulmonary metastasis. The round shape, the metastasis that appears not appears not unsurprisingly like cannonballs. Okay, so that's why this is known as your cannonball metastasis. Okay, guys, I hope you remember this. That's why again mentioning you, this is a very important X-ray for you. This is seen in your metastasis case, the cannonball appearance. Okay, let's move forward for the next MCQ. This is also the important MCQ. Moving forward, what is the diagnosis of this X-ray image shown below? So they're directly asking you about the diagnosis of it, shown the X-ray images. So I'm zooming into your this X-ray images which is provided here, and then we'll talk about the particular images. Okay, let's see here and tell me what should be your diagnosis. What should be your diagnosis by the seeing this image? I'm waiting for your answers, guys. What will be your answers, guys? I hope you saw this image clearly. Now I'm showing you the options also. The option A is your emphysema. Option B is your tension pneumothorax. Option C is your pleural effusion. And option D is your bronchiectasis. What will be your answers, guys? What will be your answers, guys? Who guys are watching live, please try to reply the answer. If you are replying correctly or wrong, no issues. I will surely correct you here. Okay. So it will be much beneficial for you when you are going for the exam. So you will not repeat the same mistake in the exam also. Okay, guys. So try to answer in the chat box. Okay. Very good. As I can see here, by the image, the options as given, the option C will be your answer. This is a pleural effusion. As I can see in the lungs, we have to see this your cardiophrenic angle, which is known as your CP angle. This is your CP angle, right? This is the CP angle. This CP angle, if is blunt there, if CP angle is blunt there, it means the CP angle is not shown there. And also, if I'm showing you about it, this is the severe type of pleural effusion, right? So blunting of your claustrophonic angle, exactly. Meniscus sign, exactly, guys. Meniscus sign, right? So this is the meniscus sign. You can see this is your claustrophonic, radiophonic, you can say, or the claustrophonic angle will be there. This is the claustrophonic angle will be there. You can see this is the normal on this side, but on this slide, I cannot identify the sign. I cannot identify this angle, okay? And not identifying the sign or the angle also, but you can see this is the fully filled with the whitish fluid. You can see this is the fluid with the fluid, not with the air. If the air will be there, the air will be the like blackish here. You can see this is the black color, air will be on the other side. But here it is the giving the white color of it and appearance of it, and it is having a level of is also there. It is having a level of it also so there. So this is the case of your pleural effusion, right? So this is the case of your pleural effusion. Now, can anyone of you can tell me what are the causes of the pleural effusion? What are the most common causes of your pleural effusions, guys? I'm waiting for the answers. What is the most common causes of the pleural effusions? Where you are seeing the pleural effusions, guys, right? So you understand the things. The claustrophrenic angle should be the blunted here. The blunting of the claustrophrenic angle is seen there, right? Also the meniscus sign is seen there. So this will be your pleural effusion, right? So this is fully with the fluid will be there. Fluid will be in the pleural effusion is what? The fluid will be going to accumulate between the your both pleuri, which is your parietal pleura and between the visceral pleura. So between this visceral and parietal pleura, we already have the pleural fluid, but it's a very minimal, right? Now it is when this is increasing, it will be going to compressing your lungs, right? So this is the pleural effusion. Where it will be seen, your pleural effusion will be most commonly seen in your TB, tuberculosis, and right, and also there will be the scene of your CA lumps. Okay, so lungs carcinoma, and in the your TB, pulmonary TB, in the pulmonary TB, you will be gonna see the pleural effusion. Okay, shifting of the trachea and the tracheal division X-ray. I will show you the shifting of the trachea in the more better in the pneumothorax. Okay, so we have the pneumothorax X-ray also, doctor, there. In the pneumothorax, right, it will be quite easy to understandable for easily for you. Okay, of the shifting of the trachea and the division. I will surely tell you. I will surely tell you about it. Just wait for that image. Okay, they will be not clearly seen to you. In this case, it will be not clearly seen to you, right, in this X-ray. So that's why I'm not giving you this particular explanation here, right? It will be not necessary also. So we'll talk about it in the pneumothorax. Okay, in the case of pneumothorax, it will be quite easy and clearly seen to you. It will be understandable for it, right? Okay, let's move forward, right? So this is the your pneumothorax. This is the case of your this is the case of your pleural effusion, right? So you can see this is the pleural effusion case. Okay, so blunting, please remember the blunting of your claustrophonic angle, the blunting of your claustrophonic angle. Okay, so this is the your pleural effusion case, right? So blunting of your cardiophrenic angle, and the chest radiograph we are seeing the most commonly. This is the used to assess the presence of the your pleural effusion. So we are the X-rays, your examination of your chest radiograph. The chest X-ray is the most common, the most commonly used in the cases of your identifying the your pleural effusion, for identification of the your pleural effusions. Okay, so remember about the blunting of it. Okay, so blunting of your cardiophrenic angle is the claustrophrenic angle or cardiophrenic angle, the both of it you can say. So this will be the more important. Okay, let's move for it. The next question is seen to you. A newborn comes with the presence abdominal lump. So the newborn is there, having the abdominal lump, and from the provided MRI, identify the medical condition. So they are asking you about the medical condition through this particular MRI, right? Okay, so what will be the your answer will be here. Options are given here. A, meningocele. Option B is your mesomeningocele. Option C is spina bifida arcuata, and option D is your bony cyst. Now I'm waiting for your answers, guys. What is the scene in your particular this MRI image? What you guys are seeing in this particular MRI image here? I'm waiting for your answers, guys. Okay, you guys are answering well. Okay, some of you are replying A, some of you are replying C. What about others? What about the others? Okay, some are saying the bony cyst also. Some are saying spina bifida. Okay, okay, okay. Just I'm zooming into it, and you can see here what you can see here, guys. Just identify this. Just try to identify this. This is your, particularly you can see this is your spinal cord is coming here, and after this spinal cord there is a bulge of this spinal cord at the lumbar area, and this bulge of your spinal cord, as you can see here, this is the bulge of your spinal cord which is seen here, is this connected to the spinal cord just behind of it. Okay, and if this is connected to this and having a big lump of it, it is a case of your meningocele. Okay, so what is this? The MRI which I shown you here, this is your meningocele. Okay, this is your meningocele. Okay, so if you're talking about the more deep about the meningocele, just remember about this image as the new important. Okay, the important image is there, right? Okay, so your, yeah, the spinal will not on the meningeal layer. Exactly, the meningeal layer will be covered there. Okay, spinal will be the separated. Spinal will be there. Okay, and now please understand this here, as the question is given, as the keyword is the newborn is given. Okay, so this is your congenital disease. Okay, so in the congenitally we are seeing there the lump will be available on the your side. So this is the case of your meningocele. This is the case of your meningocele. Let's talk about this meningocele. What is this meningocele? The meningoceles are your skin covered protection of your spinal fluid filled meninges. Okay, so this is the your meningocele, and about this talking about it, so it is covered by the skin, right? And it is having the protection of your spinal fluid filled meninges through the bony defect, through the bony defect, as I told you, through the bony defect it will be outing there. And the please understand this thing, please understand the particular thing, that this is having the posterior element. What is this having as a posteriorly? It is having this element of the spine. It is having the posteriorly having the spine, and it is without, please understand this thing, this is the without associated with the your neural tissue herniation. It is not doing the neural tissue herniation, will be not the seen there. And the rarely your meningocele should be protected ventrally, or maybe the presenting as the your intra abdominal or in the pelvic masses. So it can be maybe present at the your protected ventrally it can be produces, or maybe it can be presenting as intra abdominally, it is grow inside the abdomen only. Okay, so go inside the abdominal, so it is will be your intra abdominally, we can say the intra abdominally, which I shown you the now MRI, it was your intra abdominally. In the MCQ they particularly mentioned that the patient is having, the newborn is having a lump in the abdominal cavity, right? So on the CT MRI, on the MRI we done with the MRI, on the MRI what will be the scene? The MRI meningocele will be, MRI is showing you the meningocele. So this can be maybe presents at the protected, maybe ventrally can be, it will be grow, or it can be grow into the pelvic areas also. It can be go downside as the pelvic mass also. And as I shown you in this image it was showing you as the intra abdominally. It was growing as the intra abdominally. Okay, right? So this is about the your meningocele. Please remember, this is about your meningocele. Again, very important for you. Okay, let's move forward for the next MCQ. Right? Let's move forward for the next MCQ. And this is a question, is the theoretical question. Which among of the following radioactive isotope? Which among of this following, which radioactive isotope is not employed in the brachytherapy? So I already told you about the brachytherapy. What was the brachytherapy? In the particular, what we are giving? We are giving this particular source, which is a radioactive substance inside the body near the tumor. We are putting this into the near the tumor, and from this near the tumor, this will be going to give the radiations. It will be going to give the radiations into it. Okay, so this radiation will be going to on the tumors will be effectively. Which will be the answers, guys? I'm waiting for your answers. What will be your answers? So the options are given here: iodine 125, the option B is your iodine 131, and option C is your cobalt 60, and option D is your iridium 192, right? So I'm waiting for your answers, guys. Please try to reply me in the chat box. Please try to reply me in the chat box about the answer of this particular question. Any one of you? Any one of you guys? Okay. So this is about your iodine 131. So the answer should be here iodine 131. Please remember, okay? Iodine 125 is your brachytherapy, radioactive isotope used for the brachytherapy. Okay, iodine 125. Iodine 131 is not for it. Okay, so we'll talk about it. That iodine 131 is not used for your isotope, which is your radioactive isotope for the brachytherapy, because your iodine 131, your iodine 131, guys, brachytherapy. I'm talking about the brachytherapy. Don't be confused. I know iodine 131 is also used, but it is used for your systemic radiotherapy, guys. I know you are talking about the ablation of your thyroid gland or your thyroid carcinomas, right? I remember about it. I remember about it. But it is used in these conditions. It is not used in the brachytherapy. It is not used in the brachytherapy. It is used in the systemic radiotherapy. I'm mentioning here start, so you will remember about it. It is used as a systemic. But in the question, they are asking about the brachytherapy. So in the brachytherapy, iodine 125 is there, cobalt 60 is there, right? Very good. Okay. And this is the most commonly used in your papillary thyroid carcinoma. In the thyroid carcinoma, you already know, in the thyroid, we have to do the isotope or the radioactive substance related to your iodine. Okay. We are giving this iodine substance. Okay. So this is given iodine 131. Iodine 131 is not your brachytherapy. It is not for your brachytherapy. Okay. This is for the brachytherapy, right? For the brachytherapy is not used. This is particularly iodine 131 is used for your radiotherapy, systemic radiotherapy, right? I hope you understand this question is also very well. Remember, this 131 is most commonly used in the thyroid cancers, like your papillary thyroid carcinoma. Papillary thyroid carcinoma. Let's move forward. And remember this, if you want to ask anything related to the sessions and have any doubt related to this subject particularly, so I am leaving here my social media handles. So I am on the Instagram. My Instagram handle is your dr.Vaibhav Ahuja. Okay, so Dr. Vaibhav Ahuja is my Instagram handle, and also I have my Telegram username also. The Telegram username is your dr Vaibhav Ahuja. Dr. Vaibhav Ahuja is there. Just dot is not available there. On the both of it is quite same. Hana? On the Instagram, I have this particular dot. Okay, Dr. Vaibhav Ahuja, and on the Telegram we don't have the dot, right? So this will be the particular the both of the social medias. You guys can follow me there on my Instagram, and you can contact me on the Instagram or Telegram if you have any queries related to this particular subject or any help related to this. All right. Okay. Let's move forward for the more MCQs. Let's moving forward for the MCQs related to next. It is the newborn with your continuous producing of the saliva, and intern on duty tried to pass the nasogastric tube, NG tube. Now I'm mentioning you the first clinical or the particular word, or you can say the particular keyword. You can say this keyword is given here, that continuously producing this saliva. Okay, so this is continuously producing the saliva, producing the saliva. The intern on the duty was trying to pass the NG tube and got the X-ray done. Okay, so the doctor, which the intern doctor was available there, it done the X-ray of it, particularly passing, trying to pass this NG tube, but it is not going to pass. So he had the X-ray, and the X-ray result is showing following picture. So X-ray is showing this picture. What is the cause of this given condition? So they are asking you the cause of this condition. So first of all, going first with the related to the first of all, we are going with going to the your image. Just going to the image, and you guys can see here what I can see. What I can see, this NG tube is entering from this side. This NG tube is entering from this side, and after this, it is going recoiled. You can see it is getting coiled and again moving upside. Okay, so the when the intern doctor is trying to passing it, when intern doctor is trying to passing the nasogastric tube in this patient, this nasogastric tube is not going inside, not going inside. Okay, so it means there is a What? There is an issue in the passage. Yes or no? There is an issue in the passage. So that's why the passage, if the passage is getting blocked here, so this will be getting again. As I'm going to pass the nasogastric tube, it will be going to coiled again and moving again the further. So what will be the your answer? So option is given here, the anterior deviation of the trachea. No, there will be not possibilities there. The option B is your posterior deviation of your esophagus, right? Option C is your anterior deviation of your trasoesophageal is your septum, and option D is your posterior deviation of your trachoesophageal septum. So what will be your answer, guys? Very good, guys. Very good. Your answer should be here D. Your answer should be here posterior deviation of trachoesophageal septum. Your answer should be here D. Very good, guys. Very good. Your answer should be here D. Okay. Your answer D should be the correct answer here. So what is happening? There is a posteriorly deviation. There is a posterior deviation of your trachoesophageal septum, right? So we'll talk about it in the brief also. Just remember about this image, that particularly they're giving you the protection of the saliva, because saliva will be going to produce. It is not going to pass through this esophagus. And when the intern doctor is trying to pass in this nasogastric tube, this nasogastric tube is also not passing inside it, right? So that's why this is the particular thing which is mentioned in this particular question, right? So we have to talk about it. So the answer should be here, the D will be your posterior deviation of the trachoesophageal septum, right? So that what is the mean of is the posterior deviation of the trachoesophageal septum. What it is doing, it is the septum is causing the incomplete separation of the esophagus from the laryngotracheal tube. Okay, so it is not having the separation, it is not having the particularly separation of it. It is due to not the separation of it, particularly it is not going to separate it from here. So there is no separation, there is an incomplete separation will be seen. So there will be the laryngotracheal tube and esophagus will be not getting separated, and it is the result as the your trachoesophageal fistula, and it is going to result as the, very good, guys, it is the result as the trachoesophageal fistula, and it is going to going to incomplete formation, and due to this condition there is an incomplete formation of the esophagus, and there is the incomplete form of the esophagus is not formed very well, and this is known as your esophageal atresia. What it is known as important is here esophageal atresia. So now the esophagus is not made perfectly, so due to this the esophageal atresia, I hope you remember about your trachoesophageal fistula stages. The 5 stages are already given in your surgery image. I hope you remember about the surgical from your surgery subject, right? From your surgery subject very well. So this is the important from the case of your trachoesophageal atresia, right? So remember about it. This is the having the posterior deviation, right? Which deviation? It is having the posterior deviation of trachoesophageal, right? Trachoesophageal septum, right? So I hope it is quite interesting and quite easy question. And please remember about it. So that's why the esophagus is not completely made. The esophageal atresia is there, the esophageal atresia. Due to this esophageal atresia, the saliva which is produced by the your salivary glands in the mouth, it is not going into the your gastrointestinal tract. So that's why the patient, that's why this newborn, the already in the question the keyword is given that patient is having the protruding the saliva. The saliva is coming out from the mouth of this child, right? So when this child is lying down, this production, the saliva is dribbling from this mouth like that. Okay, so this is the your production of the saliva, right? I hope you understand this thing very well. Let's move forward for the next question, right? Let's move for the next question. The next question is in front of you, and there is a 45-year-old male with epigastric pain. So the patient is having the epigastric pain, and with this epigastric pain, the patient which is having the increasing after the meal. So as the patient has had the meal, right, after the meal, the pain will be getting increasing, and although patient is your hyperglycemia, the patient is having the hyperglycemia, and with the hyperglycemia, patient is having the your steatoria. What is having the steatoria? Was done on the investigation which is below the we had done the investigation, And during this investigation, they are asking you about the what is the true about this given. Which investigation is it? Which investigation is done in this case is about it. I'm waiting for your answers. Very good, guys. Very good. You are replying well, right? So the option are given is MRCP, MIBG, your HIDA scan, and your ERCP. What should be your answers, guys? Very good. Very good. So you can see here, this is the case of your ERCP. Very good. Right? As the question is given, the epigastric pain is done there after the meal, and your hyperglycemia is there, steatorrhea is there. So now you can identify this the image, you can identify this is the case of your ERCP. Let's talk about the more about their ERCP scan. Let's talk about this your ERCP. What is the mean of your ERCP? This is your endoscopic. It means one endoscope will be going inside with the retrograde. It means the above. Cholangiopancreatography. So this is the cholangiopancreatography. So by this you can understand the steatorrhea. It means the fat is available in your stool. Steatorrhea is there, right? And hyperglycemia. It means the effect of your what it's affected by your pancreas, pancreatic duct, or whatever. So due to the defect in the pancreas, there is a insulin will be the less. So due to this insulin level less will be there. There will be the hyperglycemia will be seen. There is a hyperglycemia will be the seen. The patient is having the epigastrium region pain. So where we have the our pancreas, right? Pancreas will be near epigastrium region. So that's why the patient is feeling the pain in the epigastrium region. Epigastrium region. So this is the particular test. This the investigation should be done, which is known as your ERCP. What is the full form of ERCP? Please remember about it. This is a very important. The full form of ERCP. This is your endoscopic. Will give the endoscope. We will enter the endoscope, which is the retrograde. We will do the cholangiopancreatography, right? And this is the endoscope procedure used to identify the presence of what? Presence of your stones, tumors, or the narrowing of in the biliary and the pancreatic duct. So which is the your biliary duct or pancreatic duct is going there. Maybe the stone is present in this duct, or the tumor of this duct, the narrowing of this duct should be identified by this ERCP imaging. Okay, so this is, you can see here this endoscope which is passing here. This is your endoscope, right? So this endoscope which is passing there. So by seeing this endoscope, you identify that this is your ERCP imaging, right? So this is the which imaging? This is the imaging which is shown here. This is your ERCP imaging. Let's move forward. Right? So this is a quite easy and good question, right? Okay, let's move forward. And there is a given, a female child was found having dribbling incontinence. What it is having? It is having the dribbling incontinence. It means the patient cannot hold the urine. Okay, it is having a dribbling of like slowly incontinence. You cannot control the urine of it, right? So urinary bladder is not controlled, right? So the urine is getting released, right? And was done an investigation which has shown the following image, right? Following image is shown. What is the name of this technique? So they are asking you about the technique. By this is showing this image of it. So I am little bit zooming in the image, so it will be quite easy to understandable for you. Okay, let's check it out. Let's check it out, this image. Yeah, I think this is clearly visible to you now on the screen. Yeah, this is clearly visible right here. Okay, this is the image, right? So can you tell me in this image which investigation is done in this particular image you are seeing here? In this particular image, which you are seeing there? I'm waiting for your answers, guys. Till now, I didn't get any one of your answers, right? ERCP was the last question, okay? Tell me about this question. Tell me about this question, which will be your answer for this particular question. Okay, I hope it's clearly visible to you now. You saw the image. Okay, let's talk about the now your options. The options are given. The option A is your MCU. I hope you know about the full form of it. VCU and the pelvic X-ray. Of course, it is not the pelvic X-ray, plain pelvic X-ray. The last is your IBP. What will be your answers, guys? First, tell me your answers. Will surely tell you about this. What is this? Okay. Try to answer from your side. What is your answers? Please try to answer from your side. What do you think? Which answer you are thinking for it? Okay. So this is a case of your related to your kidneys, right? You can see the ureter is shown to you, right? And this is the in this case we are doing the investigation of your exactly. We are doing the IVP. We are doing this the test of your IVP. Now, if I'm talking about this brief in the your IVP, it is an intravenous. We are doing the intravenous pyelogram. What we are doing? This is the intravenous pyelogram. And in this talking about an intravenous pyelogram, it is the IVP is the imaging for the task. Yes, it is a task to use to look at the kidneys and the ureter. If I want to see the kidneys and the ureter, which test I will do? I will do the IVP, intravenous pyelogram should be done. And the ureters, right? So the ureters are the narrow tube that carry your urine from your kidneys to the bladder. So if I want to show the, particularly if I want to see the kidney and the ureters, which is getting out from it, so what I will do? I will do the particularly IVP, your intravenous pyelogram. Okay. So remember about this. What is the mean of full form of your IVP? This is your intravenous. This is your intravenous pyelogram. This is your intravenous pyelogram. Right? Okay. So just check it out again. I'm showing you again the image of your IVP. This is your IVP. So in the IVP, what is seen to you? You're seeing the kidneys are seen and ureter. Can you see? This the ureter is clearly seen to you. This ureter is clearly seen to you and going to drop into your bladder. Going to the drop into the bladder. So this ureter and this is the kidney, right? So this is the kidney will be shown to you. So this is the particular from your IVP. This is the case of your IVP. This investigation is known as your intravenous pyelogram, right? So I hope this was you was not knowing or now if you are knowing well, right? So don't be confused in this. This is the technique of your IVP. Let's move forward for the next question. Let's move forward for the next question. And the next question is asking here: a female came to hospital. A female came to hospital, complain of breast lump, having the breast lump, and on the history. Now please listen this part clearly. On the history, found the have the Lee-Falmey syndrome in mother. And what we found on the history of we found that particular female, she came to you, that mother of that particular female is having the Lee-Falmey syndrome. What will be the year now screening test using in this case? What will be the case? In this case, you will use the which screening test you will be going to use. Now tell me in the chat box. I'm waiting for your answer. The options are given here. FNAC, there will be the fine needle aspiration cytology should be done. FNAC, the USG ultrasound guide sonography should be done. Your MRI should be done, and or the D option is your mammography should be done. So what will be your answers? Let me know in the chat box. I'm waiting for your answers. She came to complain with a breast lump. Yes, breast lump is present there. Exactly, the breast lump is present there, of course. But please remember, there is importantly the history is founded there. Please remember about with this history also. Don't think about it. Please remember this history also. This history is having a mystery, right? This history is having a kind of mysteries there. Okay. Okay. Don't be confused. In the starting of it, will not do the mammography. Please understand this thing. Okay. Mammography will do for the confirmatory. Now the history. I am here asking you about the screening of it. I am asking about just for the screening. Okay. Not for the confirmatory. The mammography is for the making the diagnosis or the making the confirmatory diagnosis of it. Okay. So the mammography should not be done in the cases of your screening is there. Is it clear to you? Very good. Understandable for you. FNAC is not also not for the screening. The fine needle aspiration is not for the screening. When we'll get the confirmation of it, then we'll move further for the getting which type of the tumor or tumor cells or the cytology we have to see. So we'll go for the in the depth in the later part, right? Very good, guys. Now you are moving forward by the USG. You can do for the USG for the screening, but the USG you are not getting it, it's a which kind of the lump. Just you will find that there is a lump is available there, the size of the lump you will get, but you will not get to understand that it is a which lump is there, which kind of the lump is there. So that's why please remember about it in the case of this, particularly for the screening of this mother, because she is having a risk there. She is having a risk there. So we'll go for it, and we'll go for it the MRI. For what? Very good, guys. Now you understand very well. Very good. We'll go for the MRI. We'll go for the MRI. Now you understand. FNAC, fine needle aspiration should be not done. Mammography should be not done for the screening. We are talking about the screening. In the question, they mentioned the screening. But please remember, in the screening also, she is having a high risk factor will be available because her mother is having the Pleinomany syndrome, right? So that's why there will be, what will be the use? There will be use the MRI scan. Okay, we'll use the MRI scan, not the USG scan. Okay, USG will give you the identification of that particular lump. Size of the lump will be given. Area bata dega, size bata dega particularly, but it is not giving you the clarification. It is which lump. What kind of the lump is it? Okay, for that we have to go for the MRI. Okay, for this particularly screening, we'll do the MRI scan. Okay, I hope it is clear now. Now you will be not getting confused. Don't go for the in the screening. Don't go for the mammography. Okay, don't go for the mammography. Okay, there is a more over the conditions and things are there. We have to see for the mammography, and then we have to do the mammography. Okay, we'll not do the mammography in every topic. Okay, in any conditions of it, right? Should we move forward? Okay, let's move forward for the next condition, and the next MCQ is in front of your screen. A patient was brought to the emergency with a history of RTA. He's having the history of a road traffic accident, and the patient is under the influence of the alcohol. Patient is under the influence of the alcohol was suspected. There was the rupture of bladder. Now the rupture of bladder is there, and what will be your diagnostic of choice? So the patient with the have come to you with your emergency, come to your emergency room with a history of road traffic accident. In the road traffic accident, and he is under the influence of the alcohol also. And after it, he's at the suspected. What we suspected? We suspected a rupture of the bladder. Urinary bladder is getting ruptured, right? So what will be urinary bladder, right? Bladder will be getting ruptured. So what will be the your diagnostic of the choice? I'm waiting for your answers, guys, in the chat box. What will be the your answers, guys? I'm waiting for your answers, guys. Which will be the your what will be the your diagnostic of choice in this case? Remember, with patient is having the RTA, okay. The patient is had the influence of alcohol, okay, no issues, right? Don't go for this in the deep depth of it. Just remember about it. We have to. The patient is having the rupture of. The patient is having rupture of the bladder. The important thing is there. Very good, guys. Very good, guys. You are replying very well. So the rupture of the bladder, we have to see the bladder. The important thing is there. What I have to see? I have to see the bladder. Important thing is there. So for the seeing this bladder, for the seeing with this bladder, what I have to do? We have to see with the bladder as they're talking about the bladder. For the seeing this bladder, we'll not do the USG, we'll not do the CT, we'll do the cystogram. We do the cystogram, right? Now, if I'm talking about the cystogram in the brief, so let's talk about it. What is the mean of your cystogram? Okay, so the cystogram is the imaging test. There's a cystography is an imaging test that can help in the diagnosis problem in the bladder. If you want to see the bladder, right? If I want to see the bladder, only the bladder I want to see. So what I will do? I will do the cystogram. What I will do? I will do the cystogram of it. Guys, just a minute again. This pen is getting stuck, not working on the screen. Just a minute, guys. Sorry for this disturbance. Sorry for this disturbance. So, right. So, what we'll do? We'll do the cystogram. What we'll do? We'll do the cystogram in this condition, right? So, the cystogram will be helping us into this to identify the bladder conditions. Okay, to identify the bladder conditions. Okay, so for the bladder conditions, we are doing the cystogram. Okay, yeah. I think now screen is visible to you. Okay, now screen is clearly visible to you, right? Very good. Okay, so we'll do in this condition cystogram. So cystogram should be done in this such conditions. Okay, so as I want to see the only the urinary bladder, as you the clearly the identification, the suspicion, we had suspected that there was a rupture of the bladder is seen there. So for the confirming this rupture of the bladder, what we'll do? We'll do the cystogram. We'll do the cystogram of it. Okay, so cystogram is done, right? I hope you understand about this cystogram. Okay, I hope you clearly understand about this cystogram. Perfect. So this is your diagnostic test. This is your diagnostic imaging test, which is done only for the bladder injuries. Okay, which is done for your bladder injuries. Okay, let's move forward. Should I move forward? Understand? Very well. Okay, let's move forward for the next particular MCQ in front of you. A menopausal female found to have the multiple pathological fractures. Having the multiple pathological fractures. So two keyword. First, is the female is in the menopause. The second clinical feature, multiple pathological fractures. Okay, two clinical features were seen there. On the X-ray, we say multiple fractures is seen. And what is the best radiological investigation? What is the best radiological investigation used to diagnose osteoporosis? As you already know, from the osteoporosis is the disease. From your orthopedics, you know the menopausal. After the menopause, the female is having the high, we can say the high chances, or we can say the highly for the particularly for the your after the menopause, the patient is having the more chances to get the your osteoporosis. So X-ray is already done. On the X-ray, we identified the pathological fractures were seen only. But for the your osteoporosis, what will be done? Should we do the X-ray only? No, X-ray is not going to identify it, right? Should we do all of the above? No, all of the above should be not done. Should the MRI is helpful for it? Should the MRI will be helpful for it? No, MRI will be not helpful for it. So we'll do what? We'll do the DEXA scan. What we'll do? DEXA scan should be done in the cases of the identifying the or making the confirmatory diagnosis of your making the confirmation or the confirmatory diagnosis of what? Diagnosis of your osteoporosis, for the making the diagnosis of your osteoporosis, right? So this is the case of your osteoporosis, right? So moving forward for the talking about the DEXA scan, right? What is the mean of your DEXA scan? So you will never ever forget about it. So this is the about your DEXA scan. The DEXA scan is done for your bone density scan. DEXA scan is known as your bone density scan, right? In your osteoporosis, what is happening? Your bone will be getting weakness, right? All the calcium will be getting out from your bones are there. That's why there is a pathological fractures are seen, right? So for that, we have to see the density of the bone, right? So for the density of the bone, we have to do the scan, which is known as your DEXA scan, as the DEXA scan. And this help out to work your risk of the breaking the bone. And this is helping out why our breaking bone is getting breaking down again and again. And they often used to have the diagnosis to the bone related health problems. Which kind of the bone related health problems? Such as your osteoporosis, right? So such as the osteoporosis. In the osteoporosis, we have to see the bone density, right? We have to see the bone ki density kitni, you know. For seeing this bone density, we have to do the DEXA scan. For seeing this bone density, we have to do what? We have to do the DEXA scan. We have to do the DEXA scan, right? So the osteoporosis, I hope you already know from about your osteoporosis very well from the knowledge of your, particularly from your knowledge of your orthopedics, right? And in the osteoporosis, you already know the risk factor of this osteoporosis is your menopause, right? So if the female is given clearly mentioned there, the female is having the menopause is there. So from the menopause, the patient is having the what? The patient is having the chances. The patient is having the more chances to get the more chances to getting the patient is having the more chances to getting the osteoporosis, right? So let's move forward, right? So remember about the DEXA scan. DEXA scan will give us the what? Density of the bone. The DEXA scan will be getting us the density of the bone of it. Let's move forward for the next MCQ. And the next MCQ is in front of you. Clearly mentioned that what is the best radiological investigation used to patient with the HLA-B27 positive? Now, first of all, tell me with the HLA-B27 positive, which disease is there? So we have to do this radiological investigation of it, right? So tell me what is your idea? But please remember, they are asking you about the best, not the screening or not the anything. Okay, please remember they mentioned the best also. Okay, I'm waiting for your answers in the chat, in the comment box or in the chat box of it, right? I'm waiting for your answers in the chat box. Then what will be the your HLA-B27 positive patient? Okay, you are replying the answers. I agree with your answers. Just reply me the disease. The disease. Very good. Very good, doctors. Your disease is here. Your disease is here. Very good. They're asking about the best. So that's why we have to talk about it. That's why we have to talk about it. So in this, the HLA-B27 is related to your ankylosing spondylitis, right? We talked about it, ankylosing spondylitis, right? And for the ankylosing spondylitis, the X-ray should be the basic imaging, right? If I'm suspecting the patient is having the ankylosing spondylitis, for the screening, I will go for the X-ray for the screening. But I got this thing that patient is having the HLA-B27 positive, so it is having the more chances to get the ankylosing spondylitis of it, right? So that's why what I will go, I will go for the MRI scan. Where I will go for it, I will go for the your MRI scan. Okay, so for the best radiological image, if I'm talking about the best radiological investigation in the patient of your HLA-B27 positive, right? If the positive was not given there and just they ask about it, the patient is suspect for the ankylosing spondylitis, the patient is not having the tested for the HLA-B27, so we'll go for the X-ray. We can screening, for the screening we can go for the X-ray, right? हम स्क्रीनिंग के लिए हम एक्सरे भी कर सकते हैं, बट इफ दे मेंशन दैट बेस्ट रेडियोलॉजिकल, so we have to go for the MRI. Okay, so your answer should be MRI here. So your answer should be here, MRI should be here. Okay guys, okay, should we move forward for the next question? Okay, the next question is in front of you. Now you guys have to answer very well this MCQ. This is a very good MCQ which is I given you here, and you have to try to understand this particularly, because they want to confuse you from the given a very big clinical case or clinical theory of it, right? A 45-year-old male present with the diffuse abdominal pain. I'm marking here all the keywords. Diffuse abdominal pain patient is having the shallow breathing, with the shallow breathing having the palpitation and rigidity, right? Guarding all the over the abdomen present was done erect abdomen X-ray. So what we'll done? We'll done the erect abdominal X-ray was done, and erect abdominal is shown in the X-ray image. What will be the your diagnosis? So this is the your erect abdomen X-ray is done. So I'm zooming into your X-ray, so it will be quite easy to understandable for you. Okay, just check it out here. Now tell me what you are seeing in this particular X-ray image. What you are seeing in this particular X-ray image. The options are given there. The options are given there. A is your acute gastritis will be there. B is your pneumothorax is there. Option C is the gas under the diaphragm, and option D is your hilar lymphadenopathy is given. So now can you understand and can you tell me here what you guys can see here? What you guys can see here? What will be the your answer should be here through the X-ray? About the, if I'm talking about the gastritis, so gastritis will be in the stomach, right? So gastritis stomach is not clearly visible, not the gas is having in the stomach, so there will be the no. This is the not about it. The secondly, if I'm talking about the your pneumothorax, so in the pneumothorax we have to see the blackness in the totally black will be the lungs will be seen there. The trachea should be shifted there, but trachea, if I'm seeing the trachea is the midline. Trachea is having the midline. So trachea is also the midline. There is a no sign of the scene of your particularly from the pneumothorax. So the pneumothorax will be also the not the possible. But as I'm seeing here, below the diaphragm, I am seeing the air is here. Can you see here the air under the diaphragm? So what I can see there is the air under the diaphragm I was seeing. So this is the case. This is the case. Air, or you can say right as the gas. We can say as the gas. So this is the gas under the diaphragm. So this answer should be here, gas under the diaphragm, right? So what should be the answer? The gas under the diaphragm. Okay, so the answer of this particular clinical image, please remember, as the below the diaphragm, you can see here the black air. As I already told you on the X-ray, I answered you that this is the erect abdominal X-ray was done. On the X-ray, air is looking dark, or you can say black. Okay, the air will be always looking as the dark or the black on the X-ray, right? So this is about the your question related to your gas under the diaphragm. What about the hilar lymphadenopathy? The hilar under lymphadenopathy will be the lymph nodes will be there. So in this cases, we cannot see in the hyaline lymphadenopathy, it will be not clearly visible through the X-ray, but the air under the diaphragm should be the answer of this particular image, right? So the answer should be here, C, the gas under the, or you can say air or gas should be under the diaphragm, right? Should we talk about it? What is the main important thing? So the acute abdominal pain, as the mentioned, as you are already, the keyword I showed you, as the keyword I shown you in the image or in the MCQ, which is the given by the examiner, that acute abdominal pain with the gas under the diaphragm, which is known as your pneumoperitoneum, guys, right? As is the gas is below the diaphragm, it is known as pneumo, it means air. Peritoneum is the peritoneum layer, right? So it is known as a pneumoperitoneum, and it is a medical emergency, guys. It is a medical emergency, right? Requiring the urgent evaluation of the management in the pneumoperitoneum. There is a free air in the peritoneal cavity. There is a what? There is a free air accumulated in the peritoneal cavity. And for this, we have to do the diagnosis for the erect X-ray of the chest or abdomen, right? So as we done the erect chest X-ray, we was done in the cases, and I shown you the that particular chest X-ray, but that particular erect chest X-ray I shown you in the this particular image, right? So this is about your gas under the diaphragm. Please remember, there will be the acute abdominal pain will be, the patient will come with you, and on the X-ray you will find, what? You will find the gas under the diaphragm or the air under the diaphragm. The gas under the diaphragm will be the quite easy and the quite good answer for you, right? So this is the gas under the diaphragm should be your answer for it, right? So this is about your gas under the diaphragm. Okay, please remember about this image. Again, I'm mentioning you the important here. Okay, important here, and I'm clearing this image so it will be quite easy to understandable for you. Okay, easy to understandable for you. Just remember, the gas will be, normally the gas will be not present there. You can see the gas will be not only on the left side, it will be seen on the both of the side, left and the right. I can see the gas, this gas will be on the right side also, on the left side also. On the both of the sides, we see the gas under the diaphragm, right? So this is the emergency medical condition. Okay, remember about this. So this is the very important topic, right? Remember about this. Should we move forward, right? Should we move forward? Okay, let's move forward for the next MCQ. And the next MCQ is in front of you guys, and I want everyone's answer who was watching live this. I hope it's a quite easy question and quite understandable for you, and interested question is also for you, right? So the question is given: a 55-year-old male, suspected under, given this investigation below, right? This is suspected underwent to the investigation below. What is the name of this investigation? So this particular patient is just only done this particular investigation, and it is shown to you that which investigation is done for it. So it is a kind of a USG of heart, or the Doppler of the heart, or echo, or the none of the above. Now I'm waiting for your answers. I'm waiting for your answers, guys. I'm waiting for your answers, guys. Okay, B. Some is saying B. Some of you are saying C. Okay. Okay, let's zoom in it. Okay, I'm zooming it. So I think it will be much easier to see you. The first of all thing, you saw that there is a clearly written right ventricle, left ventricle, right atrium, left atrium. So it is related to the heart, right? And the thing is here related to the heart. If you are doing, yeah, I can see this is looking like a Doppler. Of course, the Doppler USG of the heart is known as your echo. Okay, we are not saying is the Doppler of heart. Is the possible of the Doppler of that? Yes, the Doppler of heart is known as your echo. So the option is not good given. This option should be not there. Okay, this option should be not given by the examiner here. Okay, just only given by this echo. Okay, so you have to remember this is the case of your echo. You are also good. This is the kind of a Doppler of heart only, right? The Doppler USG हम करते हैं, right? Echo में हम Doppler USG use करते हैं for the heart particularly. Okay, so this is the kind of your echo. But please remember, for the heart, if I'm doing for the heart Doppler echo, if I'm doing for the Doppler for the heart, it is particularly known as your echo. Okay, echocardiography, right? We are saying like that. So let's talk about this echo. what is the mean of this echocardiography or the echo? So the cardiac Doppler, the same thing only, right? Yeah, this is a making confusion of it, and you will not understand. Yeah, this is this is the given as a previous year question, right? This is the given as the previous year question, right? So this is the wrong question. I can say like that. This is the not the Doppler of the heart. The Doppler of the heart is, yes. You can see this is the cardiac Doppler ultrasound. Okay, which is visualizing the form using the technique is called the echocardiogram or the echo, right? So echo is used as the Doppler of it, right? When we are using the echo, it's the Doppler of it only. So that's why the answer should be the echo, right? If the question is given like that, please go for the echo, right? So this is your previous year question. So if the question is coming like that, in this case, you have to go for the echo, not choose the Doppler of heart. Okay, just go with the echo, right? So the cardiac Doppler ultrasound is visualizing an image forming this technique is called as your echocardiogram, which is known as also the cardiac echo. And short saying, it is a simply we can say the echo also. We can simply saying the full name is your echocardiography, but we are saying the cardiac echo also, or sometimes we are saying the echo also. Yeah, it is kind of a tricky question. It is kind of a tricky question, right? Just please remember, if this kind of the question is coming to you, go with the echo, not with the Doppler one. Okay, this is not the good the mentioning the both of it to confusing you. I can understand some of you are going with the B, as I'm seeing the your chat box also. Some of you are going with the B, some of you are going with the C. I agree with you, but B should be not there. Okay, they have to give the other options here, right? MRI should be mentioned here. Okay, MRI should be option, should be there. Okay, right? So but go with the echo. Echo should be the your answer. Okay guys, let's move forward. Let's move forward. Okay, so the next question is in front of you, and which of the following correctly explain the given image? So this particular image is given to you, and what should be the your answer? I'm waiting for you. The single bubble sign, the gas in the abdomen, the multiple air fluid levels, and the none of the above. So I'm zooming into this particular image, so you will clearly see this particular image which is shown to you, and it is clearly shown that it is a kind of a newborn is there. Okay, so tell me, what is the scene in this particular condition? You are seeing single bubble sign. Is the possibilities there? Option A, single bubble sign is possible there? No, it is not the single. It is not the single. Right? We'll talk about the single bubble sign also. We'll talk about the single bubble sign के बारे में हम बात करेंगे. I will show you the image of the single bubble also, double bubble also, triple bubble also. I will show you. It is not the single bubble. Exactly. Very good. I hope you saw this image clearly. Let's zoom out. Let's zoom out. Okay. Now tell me, is a gas in the abdomen? Yes, it is looking like a gas in the abdomen. But sometimes I'm seeing only not in the gas. What is the scene? This is the gas, but some I'm seeing this is a fluid is also there. Okay, this fluid is also accumulated. If the gas is there, it will be looking like totally black. It will be looking like a totally black. But I can see with this there is a some fluid will be also there. Free fluid will be also available in your peritoneal cavity. So what will be the answer? Your answer should be your multiple air fluid levels. What is the mean? Yes, air will be also there and the fluid will be also there. So this is looking like this look like your multiple air fluid level. So where it will be the scene of the multiple air fluid levels. If I'm talking about your multiple air fluids level, if I'm talking about it, so on the plain X-ray, on the erect position, we done the X-ray of the particular patient, and we have found the multiple air fluid level. This is the central abdomen will reveal the factority of the bowel gases distally and confirming the diagnosis of your intestinal obstruction. It is showing us about the intestinal obstruction. So it is seen in your particularly where it will be the seen in your cases of intestinal obstruction, right? So please remember about it. So what we are seeing the air and fluid both will be available there. Okay, in this intestinal cavity. Okay, in the intestine. So there will be the air will be also there and the fluid will be also there. So it will be looking like it will be like your intestinal obstruction. It will be look like as your intestinal obstruction, right? Let's move forward. Let's move forward. If I'm moving forward for it, the next question is in front of you. Next question is in front of you. A patient was brought to the hospital after the RT. So the road traffic accident is had there, particularly the keyword. Please go for the keyword. Please remember about it. Always and always remember the one thing, in any subject or in any exam, always the examiner will give you the key points or the keyword in the MCQ only, in the question only, है ना? So ना हम लोगों ने we are saying like that question में ही प्रश्न में ही आंसर होता है ना, क्वेश्चन इज हैविंग द ओन आंसर. Okay, so just you have to see it. Okay, you have to find it. The thing is here. Okay, so if I'm talking about it, a patient was brought to the hospital after the road traffic accident or after the RTA. The conscious, the patient is the conscious. BP was just 90 to 70 mmHg, and X-rays reveal the following. What is the make your diagnosis? So now tell me what is your diagnosis of it. Just first of all, I'm reading all the options and I will go for the your particularly will go for the your image also. I will show you the image. The option is given. A is the hemothorax. Option B is your pneumothorax. Option C is your right peritoneal, right pleural effusion, and yes, and the last is your D, which is your none of the above. Okay, so let's go for it. Let's go for it. Okay. Now, I'm waiting for your answers, guys. Don't be confused, guys. Don't be confused. Just go for it and think about it. Before answering, twice think about it. What is the clinical feature in this image? Very tricky question. I think you are not going for it. You are confusing with it. Yeah, exactly. Tracheal deviation is visible. Tracheal deviation is visible. But don't go for it. I told you the tracheal deviation will be always seen in the pneumothorax. No, it will be seen in your pleural effusion also. It is not possible. It can be seen in your pleural effusion also, right? It can be seen in your hemothorax also, right? So just don't go with your tracheal deviation. Don't judge this question from the only by the bias on of your tracheal deviation. Just think about it again. I'm waiting for your answers. Any one of you, or should I have to answer it? Okay. You all guys are just answered. You all guys are just answered the pneumothorax. Just you saw about this CP angle. Can you see? This CP angle is okay, but this CP angle is blunt. The first of all the thing is here. This CP angle. This CP angle is blunt. Now tell me. Now tell me. I'm waiting for your answers now also. I'm giving you one more chance. It is not the case of the pneumothorax. Okay. Okay. Now tell me what is your answers, guys. Now tell me what is your answers you are thinking, guys. What you are thinking answer now in this cases. None of the above. Not the possible, doctor. If the none of the above, the question was not there. Okay. The question is not possible to be in this particular session. Okay. I was not going to including or the maybe in the FMGE exam or in the NEET PG exam, they will not ask you such question of related to the none of the above, right? Okay, right. So please understand this thing. Please understand this thing. I'm going to tell you about it. Please understand this thing. The pneumothorax, if the pneumothorax was there, so it was the totally blackness was there, but it is not also the scene. Yes, you can see now the trachea is deviated. The one doctor was asking the earlier, so can you show me the clearly the what is the trachea deviation? So can you see on this side there is a on this side we can see this is the your answer is the hemothorax. Very good. So as on this particular side hemothorax, please remember, doctor who are answering the right pleural effusion. Can you tell me the pleural effusion most common cause? I already told you in the starting of the chapter only, or the starting of this lesson only, the TB and the CA lungs is the most common cause of it, right? But there is the mentioned about the tuberculosis or about the CA lung, not mentioned. The patient had the RTA. Please remember, road traffic accident, had the accident, so maybe there is a hemorrhage can be there. Okay, can be hemorrhage will be there, and also it is mentioned the BP, right? Blood pressure. The blood pressure is also going down. It means slightly lower side. Okay, so there is a cause. It can be clearly seen to you that is your particularly what it is a case of your hemothorax. So what is accumulated here? Yes, the blood in the area, it is known as your hemothorax. Please just go with, just don't go with the trachea. I am again telling you, just only not see the trachea. You have to see the CP angle. You saw the CP angle is blunted. Now the option is given to you that not the pneumonia, pneumothorax will be not there, not the your none of the above. Now hemothorax and the right pleural effusion should be the options is available for you. So now you have to think about it. In this particular case of RTO, in the particular case of RTA, what will be the answer? Right pleural effusion or the hemothorax, right? So it should be always and always what? It should be always and always your hemothorax, because RTA is the main thing is here. Okay, RTA. They mentioned the RTA. If the RTA was not the mention, if RTA and blood pressure was not the mention, then we can go for the right pleural effusion also. But when they mention the RT, the word is mentioned the road traffic accident. So there will be the surely of this should be the your hemothorax. Now, if you understand this thing, and this is the earlier one doctor was asking, sir, what about the deviation? Can you see the in the case? I can show you. Now you can see the trachea is getting diverted to the normal side. Okay, so this is the hemothorax is there, so trachea will be getting diverted, right? Trachea will be moving this side, and I can show you other image also. Just a minute. We have the other images also. Yes, can you see in this image? Can you see in this image? I'm showing you with the zoom. Can you see this trachea is not diverted? Trachea is straight. Okay, can you see this trachea is straight? Okay, so now you can understand the deviation of the trachea and the straight trachea, right? So this is the clear, right? Which question you was asking for me? I hope now is it clear to you, right? Is it clear to you, doctor? If you are here live, who was asking me this question, the deviation of the trachea, I think now is it clear to you? So this is the case where you are seeing the not the deviation, there is a no deviation. You can see the straight line is seen here, the trachea, the black color line is straightly seen to you. But in the cases of it, in the case of your hemothorax, which I shown you now, you can see the trachea, you can see the trachea is diverted. Can you see? This is diverted like that. Okay, so it is not the stress, it is like that. Okay, it is like that. Okay, so this is your deviation of the trachea is also. Right, I hope is it clear to you, right? And quite confusing question, or a quite tricky question, you can say like that, that you have to think about it. It is a hemothorax or the right pleural effusion. Okay, right, not the pneumothorax. Just see the CP angle. Okay, claustropenic angle is blunted here. Okay, so this was the case of your hemothorax. And what is the mean of hemothorax? The hemothorax is the collection of your blood. What is the mean? The collection of the blood in the space between the your visceral and the parietal pleura. Okay, which is known as your pleural space, we can say. So in the pleural space, we have the visceral pleura, we have the parietal pleura. Between this, we have the pleural space. So if the blood is going to accumulate it, if the blood is going to accumulate it between between these two layers, it is known as your hemothorax, and it is known as your hemothorax, right? Blood in the thorax or blood in the your pleural cavity is known as your hemothorax, right? Is it clear for you? Give thumbs up in the chat box or like this video so I understand this thing, that you understand this particular question very well. This question is very important, very tricky, right? The examiner asking such tricky questions in the FMG and the NEET PG exams, right? So who are watching live, give thumbs up in the chat box or like this video also, right? So I will understand the thing that you are understanding this concept of this particular question. Okay, very good, guys. Okay, should we move forward? Should we move forward? Okay. Okay, I got the thumbs up from all of you. Very good. Okay. Okay. Should we move forward? Okay. Let's move forward for the next question. The next question is in front of you. One of the most common risk factor of the disease represent in the given picture. So they are asking you about the, first of all, you have to identify the which disease is shown in this particular picture. And then we have to go for the most common risk factor of that particular disease. Right? So this is a kind of also the tricky question for you. Now, can anyone of you can tell me what is the scene in this case? What you are seeing in this particular CT image? What you are seeing in this particular CT image? Anyone of you? Anyone of you can tell me? Don't go for the answers, guys. Just leave this about the options. Just first of all, tell me what you are seeing in this image. What you are seeing this in this image? Can you tell me, anyone of you? Very good, doctors. There is a case of your aortic dissection. Very good. Aortic dissection. As you can see here, this is your vertebra. This is your vertebra, and this is your aorta. In the aorta, I can see this line. I'm marking here. Just a minute. I'm zooming it. Zoom in it. So I think it will be clearly visible to you. Now it's clearly visible to you, right? Right. Just check it out, which I'm going to show you. Which I'm going to show you. This particular line, which is in the aorta, right? This is a totally aorta, right? This is your aorta. Okay, so out in this aorta we have this line, and now I'm erasing it so it will be clearly visible to you, right? So now it will be clearly visible to you. So this particular line which is shown to you, this particular line which is shown to you, this in this area, this is your aortic dissection, right? What is this? This is your aortic dissection. So now tell me, what is the most common cause? Very good, guys. As you identified from this particular CT scan, right? This is your aorta, and aorta is getting dissected, right? So this is known as the aortic dissection. Very good. The case of your aortic dissection. Very good. You made the diagnosis. Now tell me, what is the most common cause? What is the most common cause of your aortic dissection? Is the atherosclerosis, or is it the diabetes mellitus, or is it the hypertension, or the none of the above? Now tell me the answer of this particular MCQ. I'm waiting for your answers, guys. Now tell me answer of this particular MCQ. I'm waiting for your answer, guys. Very good, guys. Right? So this will be your answer of your hypertension. This will be answer should be your hypertension. As the hypertension is the most common cause of your aortic dissection, right? The hypertension should be your most common cause of your aortic dissection. So in this case, they confused you like that. Okay. So what they want to ask? They want to ask you about the particular, they don't want to ask you about the particular the question. They want to ask you, can you identify this image and make the diagnosis of it? So if you make the diagnosis of it, the question will be easy for you, right? So please remember this image of it, right? So you can identify by this. So can you identify? One doctor was asking me, sir, can you identify the structures of it? Can you see? This should be the sternum, and the ribs will be there. So it is a kind of your the thoracic cavity, and in the thorax cavity, just near the vertebra, the aorta is going on. So you can see the check the aorta. Through the aorta, you can see this, the aortic dissection should be there. Okay. So this is the aortic dissection. Okay. Let's move forward for the next MCQ. Okay. So this should be your hypertension is the most common cause, right? So as I told you, aortic dissection, the most common cause is your hypertension. Okay. So hypertension is your most common cause of your aortic dissection. Okay. Let's move forward for the next MCQ. And in the next MCQ, I'm talking about it. The question is asked that a patient with the pain in the right hypochondrium. The patient is having the right hypochondrium pain since 3 days. Since the 3 days, he is having the right hypochondrium pain. Okay, right hypochondrium, you know about the regions, all the 9 regions of your abdomen. The abdomen is divided into your 9 regions, right? And this 9 regions, in the 9 out of this 9 regions, the patient is having the right hypochondrium pain and underwent the USG. The patient went under the USG and revealed the picture given below. What is the given the true? So this image is the your USG image. Can you see? This is the USG image is given to you, and I'm zooming in into this particular image of it. I'm going to zoom in this your particular USG scan image. Can you see what you guys can see in this condition? Can you tell me what you can see here? First of all, tell me what you can see here. Then we'll talk about it. Very good. I'm getting your answers. Very good, guys. Very good. Very good. Very good, guys. Very good. Perfect. You guys are also perfect in this seeing this USGs also, right? So you can see this is showing the shadow here. What it is showing? It is showing the acoustic shadow here. And what is the acoustic shadow? Acoustic shadow of this. So this is the your, this is the what? This is the your posterior acoustic shadow. And posterior acoustic shadow of what? This is the what is your? This is your gallstone. What is this your? This is your gallstone. Okay. So we have the gallbladder stone. So the patient is having the right hypochondrium pain. The patient is having the right hypochondrium pain. Very good, guys. So it is having what? It is indicate the posterior acoustic shadows. It is indicating what? It is indicating the posterior acoustic shadows, right? As the patient is having the right hypochondrium, and we saw this is the what? This is your gallstone. The patient ko kya hai? Gallbladder stone, right? So this is the case of patient, the gallbladder stone, right? Very good, guys. So you have the knowledge of your USG also. So please remember this is the indicating of your posterior acoustic shadows. So if I'm talking about the posterior acoustic shadows, this is the most commonly seen in the calculi, in the gallbladder, right? Which is caused as the pronounced, which is known as your posterior acoustic shadows. Okay. So this is the calculi, which is your stone only, right? Very good. Gallbladder stone, right? Gallstone or gallbladder stone, that is the same only, guys. So this will be your gallbladder stone or the gallstone will be the answer, right? Is it clear? Should we move forward for the next MCQ? Okay, let's see the next MCQ is in front of your screen. The esophagus on the barium swallow. So the patient has had again the barium studies. I told you about the barium swallow. I told you about the barium meal. I told you about the barium enema also, right? I hope you remember about it. So the esophagus on the barium swallow, as shown in the image, seen in which condition? So you can see this is the esophagus. Okay, as the barium patient is having the barium swallow is there. So the barium swallow is seen in there, and also the barium swallow the patient is we have to take in the X-rays there, and this is the scene of the X-ray. Can you tell me? Can you tell me which sign is it? Can you tell me which sign is it? And the option is given to you. Option A is the diffuse esophageal spasm. Option B is your esophageal carcinoma. Option C your esophageal ulcer. And option D is your atresia cardia. I'm waiting for your answers, and in this MCQ only I will going to cover you all the options, so you will never ever forget about this particular question. Can you tell me which sign is seen on this particular X-ray? Can you tell me which sign is seen into your particular X-ray? Very good, very good. You are seeing here that it is looking like that cork screw appearance. It is looking like a screw. Okay. It is having what? It is having a cork screw appearance. Very good. Cork screw esophagus. You can say very good. So it is seen as your cork screw appearance, right? So very good, guys. It is your cork screw appearance, and you already know from your medical terminology or from your surgery that cork screw appearance is seen in your diffuse esophageal spasm, right? The first of all, I will talk about your diffuse esophageal spasm, right? We'll talk about the diffuse esophageal spasm, and I have to talk about the other options which is shown there, right? Doctor, not the B, not the B. It will be your always A, diffuse esophageal spasm, right? So the corkscrew appearance, as I shown you, esophagus is shown in your diffuse esophageal spasm. Very good, I agree with you. Now tell me what is the scene in your esophageal carcinoma and what is the scene in your atresia cardia. And about if I'm talking about the esophageal ulcer, so guys, please understand in the esophageal ulcer, the barium swallow will be not going to help you. You have to go with the endoscopy. Okay, for the esophageal ulcer, we have to go for the endoscopy. Okay, endoscopy, right? Okay, or esophagoscopy, you can say like that, endoscopy, esophagoscopy. But first of all, tell me in the esophageal carcinoma in on the barium swallow, what will be the scene? What will be the scene? What will be the scene? What which kind of appearance will be going to see? You will be going to see in the esophageal carcinoma. Any one of you? Apple core for the esophagus carcinoma. Uh, it cannot be perfectly, you can say, apple core, but for the esophageal carcinoma will be your rat tail. Okay, rat tail appearance. Okay, rat tail appearance. The rat tail appearance I will surely show you. Okay, okay, I will surely show you about the this rat tail appearance. What about the atresia cardia? The most common question which is repeatedly asked in your FMGE exam and the your NEET PG exam also. Any one of you in the atresia cardia? In the atresia cardia, you will gonna see the bird beak appearance. Okay, what will be the scene? Very good, guys. Bird beak appearance. So the bird beak appearance on the atresia cardia, on the esophageal carcinoma, you will see the your rat tail appearance. Surely, I will show you the images of this both of also. Okay, I will surely clear you with this images of both of it with the esophageal carcinoma and with the your bird beak. Okay, very good. Surely, I will cover it. Surely, I will cover it. Right. So I hope you understand now. Diffuse esophageal spasm. You will see the corkscrew appearance. Okay, corkscrew appearance will be seen here. Corkscrew. On the esophageal carcinoma, you will see the rat tail, right? Rat tail appearance. And on the atresia cardia, you will see the bird beak appearance. And on the esophageal ulcer, you will be seen on the endoscopy. The barium studies will be not going to help you in this condition, right? Should we move forward? Okay. Okay. Let's move forward for the next MCQ, and the next MCQ is in front of you. Identify the image technique employed as specific diagnosis related to this kidney. So the patient has had the kidney disease, any kidney disease was shown there, and the patient has the diagnosis related to this kidney disease. Can you tell me which kind of this imaging is there and what is your disease? So option is given MRI for the polycystic kidney disease. The CT is for the polycystic kidney disease. MRI for the horseshoe kidney or the CT for the horseshoe kidney. So first of all, I'm getting clearly it out. The option C and D is not possible. It is not joining together. The both kidneys are not joined together here, right? If they are not joined together, it will be not possible. The horseshoe kidney will be the not the possible. The possibilities, what I can see, the possibilities I can see here, there is a more over the cyst I can see. The small round spacing cavities I can see here, and these cavities are known as the cyst. This known as the cyst, right? What is this? These are your cyst. Okay, out of the cyst, now please understand, not only the cyst, as it is having the more over the cyst, so it is known as your polycystic kidney disease. And this is the case, yes, this is not the MRI, this is not the CT, this is the MRI of the polycystic kidney disease. This is the MRI of your polycystic kidney disease. So the answer should be A, right? So you can see here, I already told you in the starting of it. I will going to show you in the later part about the polycystic kidney disease MRI also. So you can see this is the MRI of your polycystic kidney disease, right? Should we move forward, right? So this is the MRI for the polycystic kidney disease. And if I'm talking about it, the cyst in the polycystic kidney disease, right? The polycystic kidney disease disease are the non-cancerous sac which is containing water-like fluid, and they have the grow very large, and it is going to getting enlarged slowly it is going to enlarge. So as it is having the water like fluid, so that's why on the MRI it is looking like white. Okay, so that's why it is seen in the on the MRI, it will show looking you the white the color of it. The next MCQ: which tissue in the body is the more or the most sensitive for the radiation? Very good MCQ, guys. Very good MCQs. If we're talking about the more sensitive, the most sensitive they asked. Please remember they asked you about the most sensitive. I'm waiting for your answers. It's a quite easy question, or maybe it is a question for your physiology, or maybe this question from you can say as from your radiology, right? You can say from the any one of your subjects, right? Any of the both of the subjects, right? Can cover if both of it. Now tell me which of it, which one of it is option A is given skin, option B is your muscle, option C is your bone marrow, and option D is your nervous tissues. Okay, some of you are saying the nervous tissue. Okay, what about others? I'm talking about others also. Anyone of you? For the radiation, if I'm talking about the radiation, can you know about the radiotherapy or the radiation, what it is doing? It is stopping, or it is making the arrest of the particular cell into the rest position, right? And that's why the radiation is moreover on the most growing cells, okay, or the rapidly growing cell, you can say rapidly growing cells, okay, rapidly growing cells. It is affecting the most rapidly growing cell. And you already know our skin is also having the rapidly growing cell also. Muscle is also having but slow growing. Nerve tissue is also very slow growing. But please remember about the bone marrow, right? So our bone marrow is having the more over the radiations, because our bone marrow is producing the our blood cells, right? Blood cells is produced by your bone marrow. So the all the blood cells will be getting the rapidly growing into the your newly growing, or you can say the newly cells also rapidly newly growing. Okay, rapidly new growing cells, you can say. So the new growing cells are where the new growing cells are where in the your this new growth cells are where in the your bone marrow. So the bone marrow is your more sensitive, right? Remember about it. So the bone marrow is your more sensitive. Very good, guys. Very good. So the cell of the bone marrow is probably highly radiosensitive. Please remember, it is a highly radiosensitive cells are in the your bone marrow. Now the MCQ is already covered. The all the previous year questions I already covered you. Now in this chapter, I'm starting to cover the more important images which can ask you in your exams, having the high length. You can see the high images also. So I will take your 10 to 20 minutes more, right? mostly 10 minutes more, right? And we're going to finish this session. But before finishing this session, I want to cover all the important images which is not asked, or maybe sometimes they ask not in the radiology, they ask in the related to your surgery, related to the medicine about it. So it is about it, right? So this is the first image which I can show you. What is the scene here? You can see this is your congenital diaphragmatic hernia. The particular image which you can say the X-ray image is shown to you. This is the congenital diaphragmatic hernia. In the cases of the MCQ, it's clearly written that the particular child is having the breathlessness, right? And you can say that we have Blotchek hernia, B hernia, you can say. So you can see the diaphragm is having the herniation. So this intestine, you can see this intestine is going where? Intestine in the thorax region. Can you understand? And due to this, the child is having the breathlessness or having the breathing problems. Although if we are passing to the NG tube, so what will be happening? This NG tube will be going like that, and after the moving it, it will be reached into the it will be reached into your again thoracic region. So it will be giving you the confirmation. It will be going to give the confirmation of your congenital diaphragmatic hernia, right? So this is the more important, all the important. जो भी मैं अब images आपको दिखा रहा हूँ, which images I am going to show you in this particular session, right? Before ending this session, the all are very important, very important. Try to reply me in the chat box, right? What is the other names of it? What is the main important questions on which is the keywords they can mention you it? The next is your pneumoperitoneum. Your pneumoperitoneum. If the pneumoperitoneum, if the air is in your abdominal cavity, it is showing you as the football site, right? It will be showing as a football side, and you can see this whole abdominal cavity. The diaphragm is pushed above, right? Because of this having the air in the air is filled in your abdominal cavity. So this is known as your football sign. This is the football sign on the X-ray, right? And where it will be going to see? Yes, it will also important sign. It will be going to see in your pneumoperitoneum. This will be going to seen in your pneumoperitoneum, right? Okay, let's move forward for the next important image. The next important image, it is your coarctation of the aorta. The next image is your coarctation of the aorta. In the coarctation of the aorta, what is the important thing? In the coarctation of the aorta, you will going to see on the aorta this figure of 3. You will gonna see this figure of 3 should be seen in this case of your coarctation of aorta. Okay, the curly B lines will be also seen. Curly B lines will be also seen. You can see this blue color mark line, curly B lines, and the 3 sign is the more important. Okay, this 3 sign, right? This 3 sign is the important for the your coarctation of aorta, for the coarctation of the your aorta, right? Yeah, inferior rib notching. Inferior rib notching will be also in the coarctation of aorta. You will see. Okay, very good. The next important image is from your tetralogy of Fallot. The next image from your tetralogy of Fallot. And in the tetralogy of Fallot, what will be the scene? You will be going to see this boot-shaped heart. I'm going to draw this. You can see this is your boot-shaped heart. So what will be the scene? It is seen in the your tetralogy of Fallot, which is your boot-shaped heart. So this is also very important image from the pediatric. The next is your related to your thumb sign. This is your thumb sign. You can see this is the thumb related to your ENT, which is seen in your acute epiglottitis, which is known as your thumb sign. The thumb sign is from where? The thumb sign is coming from your acute epiglottitis. It is seen in your acute epiglottitis, right? Okay. This is from your ENT. The next we have now talking about the single bubble sign. Let's showing you about the single bubble sign. So you can see this is the single bubble. Can you see? I can identify this is the single bubble. And what is this your single bubble? This single bubble is your stomach. What is this your single bubble? The single bubble is your stomach. So after the stomach, the gas is not moving forward. So it is your having the congenital hypertrophic pyloric stenosis, which is known as your CHPS, which is having the congenitally hypertrophic pyloric stenosis, right? So this is showing you the single bubble side. Only the one bubble will be seen there, the single bubble side. We talked about the single bubble sign. Very important, guys. Single bubble sign, double bubble sign, and triple bubble sign. We have to talk about this all the 3. All the three I will going to talk to you. The next is your double bubble sign, which I already told you. This is your stomach. The second one will be your duodenum. There will be the bilious vomiting. Please remember, in the duodenal atresia or in this double bubble sign, on the double bubble sign, in the duodenal atresia or duodenal stenosis, you can say, there will be the bilious vomiting will be seen in this particular case. But if I'm talking about it, there will be the non-bilious. There will be the non-bilious vomiting will be seen. Okay, in the case of your congenital hepatic pyloric stenosis. Okay, and in the case of your double bubble sign, there will be the scene in the question. They will mention you about the bilious vomiting. They will be shown. They will give you the case of your bilious vomiting. Okay, bilious vomiting will be there. Moving for the next third one, which is your triple bubble sign. Moving for the triple bubble sign, and this triple bubble sign will be seen in your jejunal atresia. Where will be seen? Jejunal atresia. So what will be the scene? The first bubble of your stomach should be seen. The second bubble of your duodenum will be seen, and after the duodenum we have the jejunum. So the third bubble will be seen of your jejunum, and after the jejunum we have the atresia or the blockage or the stenosis will be seen there. So this triple bubble sign will be seen in your jejunal atresia. The triple bubble sign will be seen in your jejunal atresia. Moving for the next, again for the Jenkins diverticulum. I hope you remember about it. The Jenkins diverticulum will do the barium studies. On the barium studies, we can see the esophagus. In the esophagus, we have one more outpouching is there. So this outpouching is known as your Jenkins diverticulum. Just particular outpouching is here. This is known as your Jenkins diverticulum. This is known as your Jenkins diverticulum. Remember about it. Okay. Remember about it. Moving forward for the next we have the achalasia cardia. The next we have the atresia cardia. As I told you, this is the bird beak appearance. This is the bird beak appearance. Very, very important. And the PYQ, minimum, I can say it is a 4 to 5 times repeated in the FMGE exam and 2 times in your NEET PG exam. Okay. So please remember this. This is about your achalasia cardia. It is about your achalasia cardia. So you can see this is the esophagus, and this esophagus will be getting very narrowed in the later part, and this is known as your bird beak appearance. This is known as your bird beak appearance. After the bird beak appearance, although we have the esophageal carcinoma, as I told you, in the esophageal carcinoma, we're gonna see the rat tail appearance. What will be the scene? We'll see the rat tail appearance. So you can see this is the esophagus, and after the esophagus, it will be going to narrowing down and narrowing. It is looking like the rat tail. It is looking like a rat tail, right? So this is the rat tail, one time narrowing, and the moving forward, this is the rat tail appearance is seen in your esophageal carcinoma. In the esophageal carcinoma. Let's move forward, which is the next, which I already told you, which is your aortic dissection. We already saw this sign of it, the aorta will be getting dissection, right? So this aortic dissection will be seen and the known as your tennis ball sign. Okay, I hope you saw the tennis ball. So the tennis ball is having a white strap over of it, right? And this strap is looking like that. If you're seeing this tennis ball from the side, it will from the upside, it will be looking like that. On the same cut section will be there. So this aortic dissection will be shown in the seen as or known as your tennis ball side. Tennis ball side. Let's move forward for the next. There is the known as your duplication of urinary calcareous system, and this is known as your drooping lily sign. So you can see, we can see this the ureters are seen there, and this ureters are drooping lily sign. These are is known as your drooping lily sign, and here the duplication. There will be the duplication. There will be the duplication. Can you see here? The duplication of the ureter will be seen there. So this is your drooping lily sign. This is known as your drooping lily sign, right? So the drooping lily sign is your seen in the duplication of the urinary calcareous system. You can see there's the two. This one calcareous system is coming from there. The second is coming from there. This is the duplication of it, and it is known as your drooping lily sign. It is known as your drooping lily sign, right? So marking here, this is the drooping lily sign. Let's move forward for the next. We have to see this is the known in this case is seen in the your multiple myeloma. In the multiple myeloma, what will be the scene? There will be the scene of your raindrop skull. You can see the raindrop skull. It means on the skull you can see there is a small raindrop like structures are seen to you, and this raindrop like structure is known as your is known as the raindrop skull, and this is a particularly seen in the case of your multiple myeloma. This is the case of your multiple myeloma. This will be seen as your multiple myeloma. Also, yes, you can say is the lytic lesion. This raindrop are your what? This is your lytic lesion. Okay, lytic lesions. Right? This is your lytic lesions, right? Very good. Moving for the next is your thalassemia. In the thalassemia, you're gonna see the hair on head appearance. Hair on a hand appearance. So you can see it is looking like that. The hair will be appearing on this particular X-ray. So this hair on the hand appearance is seen in the your thalassemia. It is seen in your thalassemia, right? Okay, let's move forward. For the next, we have the lungs abscess. We have the next image for the lung abscess, and in the lung abscess, you can see here, you can say particularly the crescent sign, and you can see this lung sign, this crescent sign. This crescent sign is known as the seen in the lung abscess, right? So this is the lung abscess, and having the particularly you can see this is having the filling at the having the abscess, which is having the exudates accumulation also there. This is the seen in the particular lung abscess. This is seen in the lung abscess. The next is again from the ENT part, which is known as your steeple sign, the most commonly, and the PYQ also important. PYQ 2 to 3 times asked in your FMGE exam, which is a steeple sign. You can see this is the steeple sign, right? I can draw it. So you can see this is the steeple of the church, you can say, or maybe can say the pencil tip. This is also known as the pencil tip sign. So now you can, I'm erasing it. So you can see this is the seen is the narrowing of this your larynx on this, and this is seen in your acute laryngotracheal bronchitis, which is also known as your croup, right? So in the acute laryngotracheal bronchitis, in the croup also will be seen as the steeple sign, or you can say the pencil tip sign, right? So the pencil tip, the pencil tip is also from the sharp from the edges, right? So you can see it is not going to narrow on the above of it. So this is known as your steeple sign, or also known as your pencil tip sign. Moving for the next from your obs and gynae, this is your polycystic kidney disease. Polycystic kidney disease, you can, sorry, for polycystic ovarian disease. This is the POCD. In the polycystic ovarian disease, you can see in the polycystic ovarian disease, you can see this are the cysts in the ovary, you can see, right? So you can see the more over the cyst and the ovaries, and this are giving us the appearance of, it is the particular appearance is giving for the necklace of pearls appearance. This is giving the appearance of necklace of the pearls appearance, right? Sorry for the mistake. This is not the polycystic kidney disease. This is the polycystic ovarian disease, right? In the polycystic ovarian disease, POCD, your PCOD. In the PCOD, we're gonna see the necklace of pearls, the necklace of the pearls appearance, right? So this is from your obs and gynae. This is from your obs and gynae part, right? So this is about your polycystic ovarian disease. This is for your polycystic ovarian disease, right? So that's it for the session, right? If you have any queries, I'm again dropping my social media handles. So this is my Instagram handle. My Instagram handle is Dr. Vaibhav Ahuja. The dot is here, dr.vaibhav Ahuja is there. And my Telegram personal username is your Dr. Vaibhav Ahuja. If you have any queries related to this subject or related to the session of it, right? Any queries will be there. You guys can ask me in this. You guys can ask me, or you guys can contact me on this. You guys can contact me on particular on this on my social media handles, right? So that's it for your radiology PYQ session with Dr. Vaibhav Ahuja. I hope you like this session. If you like this session, please like this video and leave a valuable comment after this. Leave the valuable comment after this video will be going to upload it there, right? I hope it was useful for you and interesting for you at this point of time. Before the exam, you was revised all the radiology subject, right? Okay. About the PDF, surely the PDF will be the link of PDF will be posted in the comment box and pinned there, right? And also in the description, you will find the link of the particular PDF, right? The PDF will be getting uploaded soon. Okay, guys. I hope you enjoyed this session with me and completed the concise the radiology. I try to my level best to complete this radiology subject with the helping of your previous year topics or previous year questions, right? And that's it for today. And goodbye, good luck, and best of luck for your preparations, right? Thank you so much, guys. Thank you so much, right? I need your likes of this. You have to like this video if you like this. If you enjoyed this session and this session is very helpful, please like this video please like this video, and after the uploading it, after the ending this live session, this video will be getting uploaded. So please leave your valuable feedback or the comment in the comment box, right? Thank you so much. Right? Okay, guys. Goodbye, good luck, and best of luck for your FMG exams from my side. Okay. Again, wishing you the best of luck. Give your 100% to your studies and be confident, and do this time your exam, right? Okay. Clear this exam, right? Very good. Goodbye. Good night.